Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing and family-centered care, its flexible design and advanced technology enables our caregivers to provide superior care to the most critically ill children in Chicago and around the world. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country, dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and include special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our Cardiac Care Unit, one of the only pediatric units of its kind in the country. The enhanced model of care combines the technology and expertise of intensive care with pediatric cardiology to provide patients highly specialized care in the same unit for the duration of their hospital stay. This incredible building is one small reason Lurie Children's is the top pediatric hospital in Illinois, but it's the people inside that make it a truly special place for kids.
Hi, I'm Todd Ponsky, founder of GlobalCast MD, and today I want to talk to you about a significant challenge that every clinician faces: keeping up with the rapid pace of new research. Every day, new studies are published, new techniques are developed, and new guidelines are released. This makes it nearly impossible to stay current with the best practices for treating patients. And not only is it becoming increasingly difficult to keep up with new ways of treating patients, the number of sources of where this content lives is also growing. How can clinicians ensure that they are providing the best care when the information is scattered across so many sources? Now there's podcasts, videos, hospital guidelines, national protocols, society websites, and more. This overwhelming amount of new information, combined with the disparities of how patient care is approached worldwide, means that clinicians often struggle to find the right guidelines or clinical tools at the right time. Another problem is that organizations who have rotating staff, such as residents and nurses, may not be familiar with the standard practices of their current hospital, so you have everyone treating patients differently. Also, when a clinician is at the bedside, they may not have immediate access to the right resources they need. That is why we developed Stay Current. It's a mobile file cabinet in your pocket, designed to aggregate and curate all the best, most up-to-date information in an easy-to-use format. Whether you're looking for current treatment recommendations, quick video refreshers, technique videos, or even the latest journal articles, Stay Current has it all. Now let's take a closer look inside the Stay Current space.
I'm Isla Senjik, and I'm excited to walk you through the key features of our app, designed to help you stay informed, up-to-date, and connected in your practice. Let's dive into one of the most powerful features of Stay Current MD, our spaces. These are customized private spaces within the app in which hospitals or departments can keep collections of their most current, up-to-date practice tools and educational tools for given conditions, such as guidelines, protocols, background summaries, technique videos, handbooks, and more. After a space is designed and tailored to meet the needs of a specialty, it's managed by a designated content manager from the institution. Spaces can be configured in 3 ways. Public, where they are accessible to all 16,000 plus state current MD users. Private, requiring approval from the content manager to access. Or a blend of both, where some content is public and the rest remains restricted.
This app ensures that everyone in your hospital, from the most seasoned physician to the newest resident, has access to the most updated information right at their fingertips. It promotes better guideline adherence and ultimately better patient care.
Let's look at how the Pediatric Surgery Group at Cincinnati Children's Hospital Medical Center designed their space. State Current MD aggregates educational and clinical tools into easily navigatable sections. This group chose to categorize their content in a way that suits their specific needs. Here, you can find trauma guidelines, which are critical for quick reference during emergencies. The resident handbook is conveniently located here, providing easy access to essential information for new team members. Clinical tools are organized in this section, offering a range of resources from checklists to procedural videos. This tailored approach ensures that all necessary information is available in one place, enhancing the efficiency and effectiveness of the surgical team. State Current MD also excels at organizing content into disease-based playlists called collections. For instance, if you're dealing with neuroblastoma, you can quickly access a collection that includes everything from the latest surgical techniques to post-operative care guidelines. This curated content is updated regularly, ensuring that you always have the most current information at your fingertips. At the enterprise level, State Current MD offers a hub space, which serves as a comprehensive resource for each institution. Think of the hub space as an umbrella that houses all institution specialties under one roof, fostering collaboration and consistency across departments.
One of the most powerful features of State Current is the ability for hospitals to share their incredible libraries of content that they have curated with other hospitals in a gated and controlled way. Hospitals can allow others to access very specific pieces of content within their State Current space. This means that one hospital can see how another leading institution is treating patients and even adopt their protocols. These customizable spaces allow you to create a personalized, aggregated list of the best clinical tools tailored to your needs.
Our search feature is powered by Elasticsearch, offering a robust and comprehensive search experience. You can search for content across the entire app or within specific spaces, making it easy to find exactly what you need and when you need it. You can share content with a colleague via text or email, favorite important resources, or download videos for offline viewing. For institutions that need a hand in creating content, we can help with that too. Another essential feature of our spaces is the key analytics data we provide. Each space is monitored to ensure it remains up to date and relevant to its users. This data allows content managers to see which content is being accessed most frequently and helps institutions optimize their spaces to meet the evolving needs of their team. State Current MD is designed to keep you connected with your colleagues and the latest medical knowledge, no matter where you are.
With State Current, staying on top of the latest in patient care has never been easier. Let's ensure that every clinician, no matter where they live or where they work, has access to the best information when they need it the most. And with the ability to share curated content between hospitals, we can all learn from each other to provide the best care possible. Thank you for watching, and I look forward to seeing how State Current can help you enhance your patient care.
Today, Children's Mercy is writing a compelling story for the future. What we are doing is strategic, fresh, new, and innovative.
Our mission is to create a world of well-being for all children. That really resonates with me and drives what I do every day.
We continue to reach new highs in every area, clinical, research.
goal in surgery at Children's Mercy isn't just to entrust the community, but to develop programs that we can expand regionally, nationally, and be first class both clinically and academically.
For more than a century, Primary Children's Hospital has represented the best pediatric care in the Intermountain West. Each year, we serve more than 100,000 children across more than 400,000 square miles.
At Primary Children's, we're the only level 1 trauma center for pediatrics in the whole Intermountain West.
Because of the expertise, a lot of patients are transferred up to us for our evaluation. And that's fabulous, and that's what we're there for. But you can imagine that is a significant hardship for the family, for the patient, and if it doesn't need to be done, it would be great to hold off on that.
We're working to provide some of the same world-class care available at Primary Children's to kids across the region, but in their own communities. In addition to specialty clinics, education, and training, we are using innovative telehealth technologies to bring our nationally recognized caregivers to more children than ever before, all while saving time and resources for the patient and their families. Telehealth can be applied to nearly limitless care types. We can connect local emergency departments with experts to help a child with a complicated injury, connect our neonatal neurologists to NICUs across the region, support pediatric medical surgical nurses in the middle of the night with a deteriorating patient, and keep children closer to home for their cancer care. As part of our primary promise to build the nation's model health system for children, we're creating one of the most sophisticated pediatric virtual hospitals in the country. With notably improved health outcomes and lower cost to families across the Intermountain West, it's the right thing to do. Our emerging model is setting the standard for others to use and follow.
I got a call from his pediatrician. He said, there's a very large tumor in Atticus's brain. So we traveled from Nashville for the very best. Cincinnati Children's is the one that helped save Atticus's life.
Do you have high-quality lectures that are stored away, never to be seen again? These can actually have incredible value, both for internal teaching at your organization, but also to be disseminated around the world. The problem is, no one goes back and watches hour-long lectures. At GlobalCast MD, we can take your recorded lectures or live events and bring them to life for the world to see by editing them into short, engaging, narrated, shareable videos or podcasts and disseminate them around the world.
with non-perforated appendicitis through their pathway and kind of out of the hospital in a timely fashion, and can we do that safely?
Putting in a drain and leaving a drain, sometimes you get away with it, and that leads to more of that behavior.
It's not a definitive evidence. This is done via a systematic review.
The bigger the nodule is, the more likely you're going to have malignancy, but all the way down to 1 millimeter, you will see tumor.
Even 1 millimeter? Wow.
You will find about 30 to 40% more lung nodules with your fingers and looking than you actually find on CAT scan.
All right, it seems like hands are very important to check for any nodules that may have been missed by radiology.
I got a call from his pediatrician. He just said, I am so sorry, but there's a very large tumor in Atticus's brain. We would go to the ends of the earth for our child, and it was the obvious decision to take him to Cincinnati Children's for his cancer care. It required us to travel from Nashville to Cincinnati. Cincinnati Children's is the one that helped save Atticus's life, and we are so thankful.
I get to ask the kids beforehand or the family beforehand if they have a particular interest, a cartoon or sports or something. Did we come up with
What do you want your bandage to be?
The flash running through.
The Flash?
Mm-hmm.
Cool, like Flash, like the cartoon Flash?
Or something with lightning.
Okay, something with lightning, done deal. At the end of a case, as everyone's kind of finishing up, I'm not hovering over everybody. I can help make this dressing kind of thing. Everybody kind of gets into it. I have a whole set of pens and pencils and stuff, and we make these things. But basically, every child I've operated on, 10,000 or whatever, have gotten a unique dressing. I have fun doing it. Kids love it. Parents love it. I had one. The dad was. It was a brownie, the elf, and the dad loved it so much that he couldn't take it off. He's trying not to ask, but basically he's like, "Can you cut out another one for me?" So if I would, I had to cut out another brownie, the elf, for him. And I wouldn't call myself an artist. I totally do enjoy doing some creative things. I do draw, paint a little bit, but I like to feel like I'm giving them something that I've, spent some time on to tell them you're not just something I've operated on. You're actually a human being, and here's a little piece of me with it. It's all really good.
All right, welcome back. We here, at least in the update course in studio, had a great lunch just now, and we're back. We're back. I know for some of you it's breakfast time, dinner time. I'm really excited about this next session, which was one of the things I learned when I came to Cincinnati from these people about the concept of better collaboration really raises the boats for everybody on specifically interventional radiology and surgery, and how combining together is so powerful. And there's so many other institutions in the country doing this now. And so I want to turn this over. So we have Tim Lutz from Lurie Children's. We have John Riccadio, who is IR at Cincinnati Children's, Amanda Wallingford, who works with John, and Dan Von Allman, who is our surgeon-in-chief. So this is the team that's going to talk about it. Thanks.
So I'm just going to make a brief statement and then leave it over to these guys. But we've heard multiple times today about the importance of collaborating and the efficacy and the efficiency and the impact on kids' lives. And so this session is really about combining the expertise of surgeons with the expertise of our interventional radiologists and ultimately impacting the patient. So you keep the focus on what's right for the patient and put the egos aside, and you can do really great things. So, John.
Amen. All right, so we'll go to the first slide. Go ahead. All right, so let's just start with a quick poll of the audience here. How often do you perform cases in collaboration with interventional radiology? This is directed at the surgeons. And really interested to see online from an international perspective
Is this
how
collaborating on a patient or actually
cases, the actual cases, yes. We can go ahead and, as we move through the results here, and, happy to see that it's an occasional occurrence for most, but as you can see, there's a significant minority where it's an almost never or even a lack of access to IR, which hopefully you'll leave today recognizing the value of these collaborations. We're really talking today about image-guided surgery, and what we mean by that is using real-time image guidance in order to enhance the care of our patients. And as Dan emphasized, this is really a collaborative effort, and so we're going to be emphasizing that over and over in our talks. Go on.
Yeah, next slide. And even when we talk about image guidance, I think sometimes surgeon and interventional radiologists may be speaking different languages. I think some surgeons may not know all that's possible with image guidance, so they don't know what to ask for. And interventional radiologists may not know what the surgeons need, so that they might not even know what to offer.
So it's important to understand that you don't have to have a hybrid OR to be able to do this type of collaboration, right? So this can occur in multiple settings. It can occur in your regular OR by bringing in an ultrasound machine. It can occur in a hybrid OR if you're lucky enough to have that, or it can occur in sort of dual settings where you go to interventional radiology, maybe you go to the CT scanner for a coil or a wire localization and then roll the patient up to the OR.
So talking about a cone beam CT, I'm not sure how many of you actually know what that is. So it's a CT scan that's performed on a C-arm fluoroscopy unit. That can be whether it's a mobile C-arm in an OR, in a hybrid OR, or in an interventional suite. Basically, it's positioned over the patient's point of interest, and it rotates around the patient, collecting multiple images, which are then stacked together to create a CT.
And I think this is technology that many people have and don't realize that they have available at their institutions, even if they're not doing it within a hybrid OR space. This is something that your spine surgeons are probably using, and you can use it in a number of kind of situations that might otherwise be challenging. So we can move on?
Yeah, and the next audience poll question, where do you perform collaborations with IR? Is it in the standard operating room? Is it either OR or interventional radiology, a hybrid operating room, or we don't? So as we wait for the results to come up, I think it's important, we happen to have a hybrid operating room, but it's really those relationships between IR and surgery that are so important, and you don't need a specialized room.
Yeah, absolutely. I mean, just talking about our two institutions, you guys are doing it in a hybrid OR. We are having our colleagues from interventional radiology come up to the OR with ultrasound all the time. And when we need to use the CT, we're generally just transporting the patients between the two locations, and both work great. So let's see the results of this poll. And so can you hover over the green? I'm curious how many people have. So about 13% have a hybrid OR, which is great. I think we'll probably see that number go up over the years. Okay, so we can move on.
Yeah, as I mentioned, at Cincinnati, we are fortunate. I think, many institutions, I think also predominantly adult institutions, you can have adversarial relationships. You've got guarded skill sets. There's financial competition. In 2002 at Cincinnati, we moved our interventional department from main radiology, which is a different floor, different building, to the peri-op area. So, you know, we're very collaborative with the surgeons. We share know-how. We still have cooperative boundaries. You know, what we're kind of moving towards a little bit in Cincinnati in those relationships is working together in our hybrid OR, which we've had open for about 7 years now. You know, there's some cross-training. We help train some of the pediatric surgery fellows with ultrasound guidance for vascular access. You know, programmatically united, we're working towards that. In fact, you know, I'm on the surgical faculty, you know, so Dan funds 1 day a week of my salary. So that's the kind of thing that we're doing in Cincinnati and in the hybrid OR. Next slide. A big important part of the program is having someone that can really champion the efforts of the surgeons and the interventional radiologists and kind of combine everyone working together. So next slide.
So I'm the program manager at Cincinnati over image-guided surgery, and my job is really to help be the liaison between the surgeons and the interventional radiologists. So I stand in the collaborative cases, make sure things go smoothly, because we all know nobody's going to want to try something new if it's going to be more complicated and take a longer time than their normal practice. So I'm kind of the person who goes and makes sure the room is set up for the procedure. I'm thinking of the things prior to it happening. Are we going to be able to get the C-arm in when they need the CT scan? Are we going to be able to do these things? And just making sure everything runs smoothly. And also a huge help is just having our leadership engaged in the program. Dr. Von Allman is a huge support of the collaborations, and so is the chief of radiology, and that has really helped. I also help train the surgeons, and when I say train, I'm not teaching them how to run the interventional equipment. It's more about building the relationships and letting them know that what we can do in the room and meeting them in person, telling them what our capabilities are, because at that point they're starting to think, how can I use these to help me in procedures? You can go to the next slide. So our hybrid OR was built so that any division can come in and use the room. It's not just sitting idle. We're doing collaborative cases with urology, neurosurgery, pulmonary, everybody's gynecology. They're coming in and using the room, and we're doing multiple procedures on these patients when they're in there. Go ahead.
So let's talk about what the barriers are. So what do you consider are the most significant factors as a surgeon that limit your collaboration with IR? So is it the scheduling and billing complexity or different financial kind of entities? Is it a physical separation, financial disincentives, or is it really an uncertainty about the benefit of the collaborative effort? Let's see the results in real time.
Yeah.
The important one for me is understanding, like having an imagination for what cases IR can really come in and add value. That would be, if that was an option, I would have chosen that one. Sometimes not knowing, oh, this is something that is a potentially tricky, IR has that skill set, or this is their day-to-day, they can come in and add a lot of value. So having the imagination for what's possible, that would be the answer I would choose.
Yeah, no, I think that's so key, and I think that's where the importance of actually having those communications. When Amanda was talking about training the surgeons, initially what this was before a surgeon would do a case in the hybrid OR, we would go over the capabilities, all that kind of thing. But really, the most valuable part of that is just what you're saying. The surgeon will say, "Oh, you think this would help in this specific case?" I'm like, "Oh yeah, this is something we always do in an IR case." So it's having those communications and that dialogue that really, I think.
Yeah, one of the things that we've talked about is, having a venue where the surgeons and the IR docs regularly meet and regularly discuss cases allows you to do that. So we have a weekly radiology conference that's always the surgeons and the IR docs, and we look at cases, and the IR docs will chime in and say, hey, we could do this, and the surgeons say, we could do that together, and then suddenly we have a case. So let's see the results. So physical separation is a big component, and then scheduling complexity. So glad to see that financial disincentives is not too big of a factor, and I'm also glad to see that people recognize that there's a potential benefit. So let's move on. And actually, we created this slide before we knew about the green, blue, and black diamond, and so we actually kind of we kind of natively created our own system here, where we're kind of talking about the spectrum of image-guided surgery, and we'll reframe it now in green, blue, and black. So moving on, let's talk about some green stuff. So routine and widely available stuff, right? So simple things, lymph node localization. You've got that supraclavicular lymph node that you can't really feel very well. You know it needs to come out. It needs more than just a core biopsy. You work together. And so let's talk about working together.
Yeah, I mean, this is a case we had. There was a lymph node kind of hidden behind the clavicle, sitting on right next to the subclavian vein. Actually, it wasn't palpable. So with ultrasound guidance, we'll just localize that with the Copans needle wire. And then, next slide.
And you guys, even if you don't have a hybrid OR, the ultrasound machine rolls up to the OR. It's one prep and drape, put the Copan wire in, and then as the surgeon, you have your breadcrumb trail, you follow it down, you find that lymph node easily, and it takes what could be a big dissection and turns it into a nice, easy case. So let's go on. Let's talk about just real simple things. Sometimes there's a foreign body that's hard to feel. Sometimes it's a piece of glass, like in this case. Sometimes it's a serpulin insertion that is broken in half, and you're trying to find the second half of the implant to get it out. Ultrasound right there in the OR can be a great tool. And oftentimes surgeons will do this themselves, but sometimes when it's a more challenging tool and you've got a friendly IR or radiology colleague, you bring them in and you can turn a slog of a case into a nice, easy procedure. I think you had some points about sort of when and where to use the ultrasound.
Yeah, I think when I'm asked to come in and help out a surgeon that's been rooting around in there for a while, you get very skillfully rooting.
He's not speaking from experience.
You actually introduce some air around that foreign body. So when you're ultrasounding, it's really hard to see it. So if you know that something might be challenging beforehand, maybe give your IR colleague a call, and we'll go ahead and localize it before there's introduction of some of that air, which makes things virtually invisible.
And quick comment, and I've used ultrasound on ones that you can see, and then you can actually use your hemostat or that sort of thing, see that advancing under ultrasound guidance, put a little water in there to be able to see your hemostat going in, to see the piece of glass, and then you can see the two ends of the hemostat go around the piece of glass and then pull it back out for the really deep one. So then you can have a small opening.
Yeah, we'll do that. We'll go down and we'll hydrodissect around the foreign body. So we'll hydrodissect with some saline, and just like you're saying, get a forceps down in there and remove it.
Yeah, and then I think there's all sorts of ways that people use intraoperative ultrasound. We could probably do a 30-minute talk just about this. And, again, this is something that, depending on the circumstance, is something that the surgeons will do on their own, or bring in a colleague when it's, something that's a little bit more involved, right? And so you can use it for looking at margins and the partial nephrectomy. We talked about that earlier, mapping out your resection with the ultrasound. For sarcoma excision, there's lots of data about using it to sort of define your margins during those, and likewise in hepatic resections. You can also use it for identifying and protecting critical structures during surgery. So we all know during those terrible neuroblastoma excisions, when you're creeping up the aorta and you're trying to see where the celiac takeoff is, I'm looking with the ultrasound every 5 minutes during that case and reorienting myself with the ultrasound. I know the liver surgeons also, will use it all the time as they're looking at when the middle hepatic vein is sneaking up during a complex resection. And then you can use it at the end of the case to confirm vessel patency. So, the transplant surgeons have been doing this forever, whether it's, looking at the flow in a kidney transplant at the end of a case, or looking at portal flow after a mesorex bypass. But also, again, on that hard neuroblastoma excision where you've really skeletonized the renal hilum, just reassuring yourself that the renal flow looks good at the end of the case is an easy and great use of these tools. So we're going to talk about kind of two different ways. There's all sorts of different ways to do pulmonary nodule localization, and many of them involve collaboration between surgery and IR. You can do it with a wire, you can do it with a coil, you can do it with dye, do it with whatever you're most comfortable with at your institution. The way we do it at Lurie is we actually make use of two different locations. So we go to the pre-op CT. Our IR colleagues will go in under CT guidance and leave a coil right next to the nodule. And then in the OR, we'll use fluoroscopy under two different orthogonal planes. So you got to look at one angle and then move it 90 degrees to make sure you really have the nodule and remove it. I like this approach, sometimes combined with a dye, because you're not at risk for wire displacement. Now, I think the people who use the wires, which John will talk about.
Yeah, at Cincinnati, we use a combination of methylene blue blood patch as we're going in. So we'll basically we'll do a cone beam CT, ideally with the patient in thoracoscopy position already, so it's one draping and one prepping. This will be in the hybrid OR. We'll do methylene blue blood patch tattooing of the visceral pleura as we're going through it with the Copans needle, and then we'll deploy the Copans wire. I remember when we first started doing the methylene blue. Actually, this dates back to Fred Reichman. I don't know if you know this story, Dan. We were doing it down in CT, and we didn't really know how much to put in, and so we went in and put in just methylene blue, like 0.5 of an ml, and then we sent the patient to the OR. So Fred calls back and says, "Yeah, thanks for letting me know which was the blue lobe." The entire lobe was blue. So the blood patch is a key component of the methylene blue we found.
What are you guys using to localize your pulmonary nodules? And you can answer E if it's none of these above, but something else. So I know some people are using ethadiol and some different things. I'd be curious to see. Bhargava, yeah?
Yeah, at our institution, I've sort of gone away from wires mostly because we have to travel from CT up, dislodging, all kinds of stuff, right? So basically we're doing intraparenchymal ICG injection if it is superficial enough. Just that 20 times the dilution, so 0.125 milligrams per ml, just a very 0.1 cc's is all you need and just kind of lights up. But if it's beyond 2 centimeters or deeper, you really can't see them, and then we leave the coils and use the C-arm to find it.
And remember, don't forget about your cone beam CT. If you do the coil and you have trouble finding it, you can bring that mobile C-arm to the OR and do a spin to find that coil and get it out. So it looks like people are not learning to use IR. They're just doing fluorescence-guided surgery and giving ICG, or if you're really on the cutting edge, Cytolux, which we could have a whole other talk about. People are doing wires and coils and then none of the above, which I assume either means anatomic localization, thoracotomies with palpation, or maybe some of the other localization techniques. I know we only have another minute or two. People are doing all these different approaches, so we can move on. And let's talk about some of the blue things. So vascular malformations. These things are often managed in a multidisciplinary VLC clinic. The IR folks can offer sclerotherapy. We can offer resection, and sometimes a combination is the best. So if you have something where it's not really amenable to sclerotherapy, they can still do angiogram essentially and directly inject it and get a contrast study and then put glue in it, so that if you have these little outpouchings, these little legs, you can make sure that you're getting those fully resected at the time.
And just collaborations with our interventional pulmonologist, where we'll help them with transbronchial biopsies. And we'll do a cone beam CT, we'll segment out the 3D anatomy, it takes about 1 minute, and then our live fluoro, next slide. The live fluoroscopy will be, there should be a movie there on the right, the live fluoroscopy will be superimposed over this nodule, so in AP and a lateral view, they always know where they're going to be performing the transbronchial biopsy.
Yep. What's the glue you're using for that vascular case?
Ethadiol, I think, right? Yeah.
For the vascular case, yeah, it can be. I know we've used Onyx. We've used just regular standard glue for all of our embolizations that we typically use for vascular. So N-acetyl-butyl.
I just asked for glue and they gave it to me.
Yeah.
It might be Elmer's. I don't even know. All right, next slide. I know we got to wrap up here.
Next slide.
Keep going.
Yeah.
You know, I'm really excited about robotic bronchoscopy. We're doing some research on this right now, but you know, the adult thoracic folks are using intuitive ion, right? You're just using the preoperative CT instead of a real-time CT to map out your route and do these biopsies, and I think this is coming soon to pediatrics.
Yeah, I think this is.
And then finally, the black diamonds. We'll do 30 seconds of black diamond.
Yeah, this is really just, yeah, you can click on this. And, you know, I think virtual reality, augmented reality, that's I think, going to be part of the future for sure. Trying to figure out what is sexy and what is sexy and actually clinically useful are another couple things. But here's another, on our IR research lab, which kind of mirrors our clinical hybrid OR. If this movie plays, basically, it's just a holographic display superimposed over your patient on the table. So you take either pre-procedure CT, MR imaging, segment that out, and actually co-register it to your patient. And then you know the technology can track instruments, you know, kind of like Brain Lab does for the neurosurgeons. But that's definitely coming along, and I think when they're able to track movement. I don't know if it's playing out. When they're, oh, there. This is in the hydrocephalic sheep model, like 1 day old, that we did a MRI, and then they're superimposing that holographic image, you know, over the anatomy. And there's fiducials, so you can match everything up, and then actually slice through virtually with hand gestures the anatomy to see that those dilated ventricles for EVD drain placement.
And then we'll just end by asking you to put into the chat box any other innovative things that you all are doing to combine IR and OR resources. Thank you.
That was awesome. Thank you, guys. And I mean, this is, I can't wait to watch this every few years to see how collaborating. You know, it's interesting at, my brother's a urologist, and about 15 years ago, he called a meeting with all the surgical specialties to come together and share toys. And since then, I've been doing operations with a hysteroscope, with a neuroscope, with a ureteroscope. I mean, so it's great to start sharing tools and techniques together, and we're all gonna get much better. Thank you.
A colonodoscope is just your ureteroscope.
Ureteroscope, that's right, yeah. All right, so we are doing our next session on undescended testes. Sean, why don't you come on up? It's gonna be moderated by Sean St. Peter from Kansas, what is it? Kansas City Mercy, no, I get it wrong. Children's Mercy, Kansas City. And we have, I can never remember the order of those words. And we have Dr. Sami Shahata, who is beaming in from Egypt. So is he online? Sami, are you there? No?
Yeah, hello.
Sami,
hey, Sami.
My friend, how are you? Good to see you. Thank you for joining us.
I'm fine. Thank you so much.
Looks like you're in Norway, but thanks for joining us. All right, I'm going to turn things over to you, Sean. Thanks.
Hey, Sami. Welcome.
Hello,
Thanks for joining
Sean. How
us.
are you doing?
Yeah, good.
Great pleasure. Thank you so much.
I'm not sure how many people know about the Shahada technique, but I'm going to let the video play. Do you have anything you'd like to say before we show the video? Sami, would you like to say anything before we start the video?
Well, it's a great pleasure to join the team here. I am online virtually this time, but I hope next time I'll be meeting you all in person. And I know that there is a big audience online watching this, so it's a great pleasure to join all pediatric surgeons in different countries of the world. So my talk is about, as you mentioned, you don't know how many are practicing the Shahada technique, so maybe we'll get this answer in the poll that will be in 59 seconds since the start of my video. We'll know exactly how many audience are practicing the technique, and then let's discuss, can I convince you if you are not doing it, or you give me your feedback.
Wait, before we roll the video, I just have a quick question. Sorry.
Sure.
How many in this room do take care of undescended testicles?
Intra-abdominal testicles.
Well, okay, so you want to separate it out?
I do, because some places the urologist will focus on intra-abdominal testes.
Yep,
and
okay. So
that's what his technique's about, is the one that won't come
right,
down.
so let's start with, I mean, we could have fun going through all the different urologic, with the urology, pediatric surgery battleground here, because it's different in every institution. But I think this is one of those things like thyroid where not everyone does this at every institution. Some of it goes over. I know we've had some agreements, at least in Akron, about splitting it up. So I just wanted to know. So it sounds like almost everyone here deals with both inguinal and intra-abdominal undescended testes. So perfect. Let's roll the video.
Hello, everyone. It's my great pleasure to join you today at the update course in pediatric surgery. My topic is updates in the management of intra-abdominal testis. And we'd like to focus on the effect of division of the main blood supply as we see in the Fowler-Stephen approach, and which technique is better for intra-abdominal testis if we remember the historical techniques for elongation and stretching of the testicular vessels. And we need to look at the potential complications of each of these techniques. And before starting, we'd like to send a poll to the audience and to know which is your preferred technique in the management of high intra-abdominal testis. That's Fowler-Stephen, Shahata technique, lab-assisted single-stage orthopexy, or microvascular anastomosis.
Is there a way to see the polls? Can we pull them up? Oh, Isla, can you share the poll? Isla, I don't know if you can zoom in on that or not, but but it's hard for us to see. There we. Ooh, nice. Okay. Looks like the majority are Fowler-Stevens, Semi.
Yeah, I expect, but there is a good 1/4, I think, if I can see well, doing the Shahata technique. Is that correct, Todd?
Yeah, there's confusion because lap-assisted orthopexy is going to involve the Fowler-Stevens. So most of us, even if you're dividing the vessels, you're going to be doing that laparoscopically. So I think that they kind of fall together as non-Shahata in that whether you're doing a lap-assisted with or without dividing the vessels, we're not committing to stretching the vessels. So go ahead. Looks like about a third.
Okay. Okay. Thank you so much. So we can continue the argument. Maybe I can convince more percentage of people to do the technique. Can we resume the video? Yes. We can see that the most popular techniques right now are the Fowler-Stephens and Shahata technique practiced in many centers around the world. And you can see that both they enjoy a similar success rate between 80 and 90% with marginal difference. But probably the main difference is in the preservation or division and interruption of the main testicular blood supply. This important publication by Pepicelli and group as an animal experiment has shown the effect on volumetric and histological findings in intra-abdominal testis before and after division of the spermatic vessel. They came to the conclusion that ligation during orthopexy can lead to a significant reduction of spermatogonium. However, no significant changes are observed in the volumetric characteristics of the testicles. That means, in simple words, you are bringing down a good-sized testis, but it is of poor quality. So here we are looking at, of course, we need to be concerned about the success rate, the atrophy, the testicular ascent, but again, we need to see the effects of the interruption of the main blood supply and if there is possibility for the preservation of the testicular blood supply. We have been performing the Shahata technique for more than 15 years now, and this is the main concept of the Fowler-Stephens approach. In case you have a high intra-abdominal testis, you cannot bring it down, so you interrupt, you divide the main testicular blood supply depending on small collaterals. to be able to bring it down. And actually the idea for the Shahada technique came from this observation, which I'm sure all pediatric surgeons have seen in a case of huge hydrocele or inguinal hernia. You can see remarkable elongation of the spermatic cord. This time it happened when we don't need it. We don't need, for any reason, to bring the testis near to the knee of that child, but there are a bad need for having this elongation in high intra-abdominal testis. So this is a concept for the Shahada approach. That's for the same high intra-abdominal testis, you cannot bring it down. Then you fix it with a stitch to the contralateral anterior abdominal wall and leave it there for a period of 2 to 3 months. Allow significant elongation to occur, and then you bring it down without dividing all the testicular vessels. So we have been able to, since the year 2006 until 2020, we have been able to operate on 430 cases with a mean success rate of 88%. We have 7% slip traction, which we can successfully do a redo traction. So regarding the complication, we have no case of internal hernia. Adhesions were extremely minimal during the second stage, slip traction in 7% and smaller or higher in 12%. The worry of surgeons about the occurrence of internal hernia when a cord is crossing the abdominal cavity, actually, it has never happened in more than 15 years, in more than 430 cases, and in many centers around the world, has never been reported. And it's probably anatomically impossible when we tried during surgery to bring the bowel behind the cord. It was not possible. So I assure you that this complication does not happen. So the operative time is short in the first and second stage. And you can see that the possible mechanism for elongation, actually it is in the gentle and gradual abdominal wall movement during respiration, and even more likely that this is because of the weight of the bowel, small bowel, on the cord of the spermatic vessel that's very gently and gradually causing this elongation. So this is our preliminary study in Pediatric Surgery International in 2009. This was a small number of cases, 12 cases. And this is more firm conclusion that in Journal Pediatric Surgery 2015 on 140 cases, we got more solid results and longer follow-up. We have recently 3 systematic surveys and meta-analysis documenting the results after the Shahada technique and comparing the Shahada technique with the Fowler-Stephen. They have similar or better outcome for the Shahada technique, and they need, of course, further prospective studies. A conclusion that they are both comparable, and some studies has shown better results for the Shahada technique. So in conclusion, I can say it is the technique of Shahada is suitable for the majority of intra-abdominal testis. It is safe, reproducible, and it leads definitely to effective elongation, and most importantly, is a preservation of the testicular blood supply. If you compare Shahada versus Fowler-Stephen, the OR time is much shorter for the Shahada technique. Waiting period is 2 to 3 months compared to 6 months. Adhesions are much less, and technically is much easier and is more reproducible. So at the end, I thank you so much again for the invitation, and I'm happy to take any question. Thank you so much.
All right, Luke.
Dr. Shahada, this is a great technique. I've got one coming up next week, and I'm going to use, people hold me to it, I'm going to use this technique in the operating room. I've not done it before, but it seems like it's very approachable, straightforward. One question I had for that pexy, I mean, I almost envision wanting to throw a stitch through the abdominal wall to catch that testicle on the contralateral side where I want to pexy it, and then I can bury that, if it's, especially if it's an absorbable suture. Is that a reasonable thing to do? A little small 2 or 3 centimeter or millimeter incision, putting that needle through, catching the testicle, coming back out, backing the needle out to keep it all buried. Is that what you propose, as a way to fixate against the contralateral wall? Thank you.
Thank you so much. Exactly like what you have described. It's a percutaneous stitch, non-absorbable. I prefer Ethibond 2O. You pass from outside and very gently go through the tunica albuginea and back, and you tie it under the skin, and you leave it for 2 to 3 months. For the sake of time, I did not show the video, but it's present now on the web search and on the YouTube, and I'll be happy to send it to Todd and Sean. If anyone would like to see more details, the video will explain everything.
That's great. And you could put a link in the chat as well. So that was phenomenal.
Yeah, for sure.
Yeah, just to add to the discussion, we had done a randomized trial. It was a pilot study, small, 13 in one arm, 14 in another, comparing 1-stage versus 2-stage Fowler-Stevens in those patients who required testicular vessel division. And we saw no difference. Both groups lost one. So that wrapped up 10 years ago, and since then we've only been doing laparoscopic single stage, and we've not been losing, haven't seen personally a lost testicle since then. So I thought we'd kind of answered that question, and what Sammy's introducing is an entirely new debate, which is keeping the vessels intact the whole time. It pushes us back to 2 operations, but it means you don't have to divide the vessels. And so what we had migrated to is assess whether you're going to have to divide the vessels before you take down the gubernaculum. So there's 3 blood supplies, one from the vas, one from the gubernaculum, and then of course the testicular artery. And if it's clear it's not going to come down, and it's usually pretty obvious that you can drag it and it's redundant or it's tight, in which case leave the gubernaculum, divide the testicular artery, and then you can bring it down on the vas. So you keep 2 of the blood supplies. And the difference is you're not going medial to the epigastric vessels, you're just going straight down the canal, so you preserve your gubernaculum.
But I think what Dr. Shahada showed that is critical is
decreased spermatogonium.
Yeah.
Yeah.
So I think you really want to try to preserve that testicular vessel if you can. That was the most striking thing.
There's a great theoretical advantage to keeping the artery. It's just that it pushes us back to 2 operations. And if he's proposing a study that's comparing these 2, which I think would be reasonable, I think you would require testicular biopsies to replicate what was seen in an animal study.
This is phenomenal.
Yeah, exactly. I feel that the final answer will be if you can compare with biopsy histological study, you compare Shahata with Fowler, and I think this will give the final clue. But the problem is ethical consideration, of course, and consent for biopsy.
This is great. John DiFiore over here just said it's going to be really hard to go against anything you say because you look like God on the screen there. So this was a phenomenal session. Any other final comments?
So an 88% success rate was mentioned, but what's the definition of that success? Is it just bringing it down, or how much atrophy or size discrepancy would you tolerate to call it a success in that series?
Yeah, that's a very good question. Success is defined as a testis in good position and good size, not less than 25% less than the normal for the age, and with good vascularity by Doppler ultrasound.
Awesome. All right, that's great. Thank you so much.
Reagan and Katie.
Awesome.
Thank you so much. Great.
Sammy, thanks for joining us. I don't know what time. Sammy, are you still there?
It's 8:30. I'm going to my private clinic right now.
Okay, get to work.
Yeah.
Thank you, Sammy. It's so good to see you.
Thank you so much.
Okay.
Thank you so much, Todd. Thank you. Bye-bye.
All right. I love, this is very high yield. Every few minutes I'm learning something new about how to change the practice. All right, speaking of which, Katie always teases me about my lack of knowledge of updates in trauma. We are going to talk about trauma now with Katie Russell, who is at Primary Children's in Utah, and Regan Williams, who is at Le Bonheur Children's Hospital, and is a million incredible titles, by the way, and that's pretty impressive. That's going to be running the hospital soon. All right, so you're going to be talking about updates in trauma.
Let's do it. black diamond.
Particularly at the end. All right, thanks for having us. We're going to give you a couple updates in pediatric trauma. The first is on vascular trauma. Then we're going to switch to DVT prophylaxis with Katie, and then we're going to end with REBOA. And if you don't know what those letters stand for, we'll talk about it. So our first case is a 16-year-old female who was in a motor vehicle accident and presented in shock to your emergency department. This is her imaging. She has a grade 5 splenic injury and a blunt grade 2 thoracic aortic injury. Think about what you would do. So in this room, for her thoracic aortic injury, what would y'all do at your centers? Luke?
We're going to deal with the life-threatening issue first, right? I mean, obviously, that wasn't highlighted, but oh yeah, deal with the life-threatening injury first, right? So take out the spleen if that has to happen. I know that's like anathema. If there's head injuries and things like that, you could think about doing that. But deal with the life-threatening thing first, depending on how they respond. And then I think you have to, it's a little bit of a push-pull. You'd like to use beta blockers. You'd like to use, pressure control of the aortic wall to help, but that may not be feasible if you're in an active resuscitation for this patient that's otherwise very sick and maybe concomitant injuries. So, I think A would be my initial choice if the context allows itself.
Who in the room would take out the spleen? Anybody?
It's grade 5, right?
Grade 5 spleen.
In shock.
Presents in shock. Hasn't gotten blood yet.
Oh, okay, well, come on.
That's actually a legitimate question because when we look at it nationwide, the majority of splenectomies happen before they actually get blood. I mean, I know you wouldn't do that, but...
I know. Well, I have, so in full disclosure, I've taken a spleen out in the last 5 years, but it was in a 15-year-old with a bad head injury and was getting resuscitated and not responding.
So, good point. This patient became stable after blood transfusion, so we did not have to take out the spleen. However, we did take the patient to IR because of the splenic injury, and we didn't know about the thoracic aortic injury until they were in IR, which was sort of interesting. So let's go to the poll and see what everybody feel like. Oh yeah, sorry, thank you. Okay, this is super awesome. So 48% of people would do endovascular repair with stent placement. 37% would do beta blockade. 13 are going to repeat imaging, and nobody would do an open repair on cardiac bypass. So, next slide. This is super interesting. Thoracic aortic injury is very, very rare in children, so you're almost never going to see it. But in a national survey of what we do, actually about 67% were managed non-operatively, which kind of goes in line with what we saw in our poll. 27% were managed endovascularly, and 6% were managed open. The important thing to note is that non-operative management may not be the right treatment for children with these injuries because they may progress. And you actually have better outcomes with endovascular repair than non-operative management. So I think that depends a lot on the age. My guess is that the people who are doing non-operative management, they're very small children, and they don't want to put a stent in them. What do y'all do?
Well, I was just thinking about it. It's a case-by-case basis. It's so infrequent. And then there's also the questions about who do you call? Is this the cardiac surgeon that helps you? Is it the vascular surgeons from across the street? Is it IR? I think at our institution it is not totally consistent.
Yes.
Regan, can I ask you a question about, you said that you didn't know this was there until the patient went for the embolization, presumably when they injected dye or something, you saw it there. So is there an incidence of undiagnosed aortic injury in children that you're just missing when you say, when we look at the data, and that those kids are effectively managed non-operatively and do well?
I do think that we do miss some of them. We actually had looked at the scans, and it was the radiologist review, like the attending radiologist 3 hours later, that found the injury. We just missed it when we looked at it. But I do think that there are injuries we miss because children are really small, and if they have like a little intimal repair, you may totally miss that.
And then also we've been pretty aggressive about trying to convince people not to scan the chest in kids.
True. When should you scan the chest in kids? We could go on and on with this.
We could. you need, so this would be, my statement's gonna be controversial, but you definitely need to scan the chest if you're worried about the chest x-ray. So if you think that there is mediastinal widening on the chest x-ray, that is a concern for some kind of great vessel injury that definitely needs a CTA of the chest. I personally, in the really sick kids, where I want to scan the neck and I want to scan the belly, I personally scan the chest, though I know not everybody does that.
Yeah. So this patient definitely got scanned because they were in shock. They had a slightly wide mediastinum on the x-ray. The mechanism, even though we said sometimes that's not important, and that's how we found the injury. And this patient, I was on call, and we consulted vascular surgery to review, and they wanted to do a stent. And I thought that was a terrible idea, so I called the main vascular surgeon, and she was in Egypt, and she said, no, Regan, it's okay. You can put a stent in them. And then I looked at this paper, which is right here. It's a 10-year review looking at NTDB data that actually shows TVAR is very safe in children, that it decreases mortality. It's going to decrease risk of spinal cord injury from doing an open procedure, and it gets them out of the hospital faster. Also, I've been working a lot with the SVS and the Society for Vascular Surgeons, and there's really small stents that you can use in children so you can deploy and get these things repaired. And then this was a 16-year-old. So 16-year-olds are really close to adults. And if you look at the adult SVS recommendations, it would 100% be for endovascular repair. So if you have a patient with a thoracic aortic injury, I do want you to consider getting it repaired, and that might be interventional radiology, it might be vascular surgery. It's going to be different depending on what your hospital has.
Was there an age that that paper went down to, or was it all children?
So the paper, it did all pediatric children, but it was really weird in how it separated them because it did almost down to 2, but it also went up to 21, and then it made them child, adolescent, and pediatric. I don't consider a 19-year-old to be a pediatric patient, but that is what the paper did. But it did include the smaller children, and when you looked at treatment, the younger children were more likely to be managed non-operatively. But you can use an endovascular repair if you need to in those children. You just have to use a really small stent. So they have expandable stents now, and you can actually, I don't know all this stuff, but I just listened to a vascular surgeon talk about it at VAM this year, and they have these expandable stents that they go in as they grow, and they make them bigger with a balloon. Any other questions, comments? All right, we're going to go on to our next one.
All right, guys, I want to tell you about a 15-year-old who is in a high-speed motor vehicle crash, is hemodynamically normal with a hematocrit of 28 in the trauma bay. But he's got several injuries. He's got a 3-millimeter subdural hemorrhage that is stable on a CT scan 6 hours after injury. He had an operative pelvis fracture, and he's going to be non-weight-bearing for 6 weeks. Now, this might be black diamond. It might also be very boring for some people out there, but we think it's important to talk about. So, in terms of many of us went through general surgical residencies, and we know that we talk about DVT prophylaxis, right? And basically every surgical patient that's in the hospital, we talk less about it in kids, but again, this is a 16-year-old that's had serious trauma and is going to be in a wheelchair for 6 weeks. So when should we start chemical DVT prophylaxis in this kid? I think we pretty much all believe that people should all have squeezers. All adolescents should probably have squeezers in the hospital, but when should we give Lovenox or something like that?
I'm curious in the room here, because this is where I was schooled up by our trauma NPs, because I'm so afraid of giving anything. I'm just curious, how do people respond to this in the room here? Any comments?
Within 24 hours. And this is the big challenge is that the neurosurgical community is in large denial of the data, that says that it's safe to do and that if you don't do it, you have big complications. The trauma world gets it. The literature's clear. I just don't understand what's the barrier in that world.
And this is a non-operative head. Right? So it's a non-operative head, a very small head bleed, a kid who has a GCS that is normal and now has a repeat head CT that is stable.
But this is true for any time there is a potential bleeding organ, when can you start DVT prophylaxis?
Yeah,
right?
so we're getting some right nows in the audience. I think this question really came out of a paper from the Midwest Consortium. So a bunch of you guys are in that. Does anybody want to give us the highlights of that paper? I'll highlight it for you, though I'm in the Western Consortium. So Dr. Ehrlich, he was the senior author, and I think her last name was Witt, Amanda Witt or White. So, they looked at it and found that in trauma patients, if you gave DVT prophylaxis within 24 hours, so within 24 hours of injury, they are much less likely to get a DVT. So I think our goal should be, and I don't know what you guys are doing, but our goal should be really to start within 24 hours.
Yes, and what we do now is the trauma surgeon decides if the patient's going to get DVT prophylaxis, because we found that the neurosurgeons, they don't even necessarily say no, but they sort of like dance around it, and then the PICU decides that they're not going to give it. And so we wrote the protocol that you just ask the trauma surgeon, and what the trauma surgeon says is what we do.
What about solid organ injury?
You can absolutely give DVT prophylaxis in solid organ injuries.
Pelvic injury.
Yes. I mean, I think once the patient's stable.
Yeah.
And I think that's the thing that she said here.
Then tell me when I should not give it.
ISS less than 25.
You're smart, dude.
Now, why would you say that, Luke?
Yeah, why? We don't know the ISS, right? They're in the hospital.
For less than 25. Yeah, usually that's a retrospective thing.
Yeah.
I mean, you can calculate it, but nobody does that. But the East guidelines, which are I think the best data we have, which is not great, and I'll be the first to admit, pediatric guidelines in the grade format tend to not be very robust because the data is just not there in aggregate. But they would suggest that for adolescent patients with an ISS greater than 25, they need to get prophylaxis. And that's about all they can say.
That is true. This is a 16-year-old, so you can treat them like an adult if you want.
The pelvic fracture guys are not scared of DVT prophylaxis because they're all adult surgeons for the most part, and they've lived in this world of DVT prophylaxis for way longer. So typically, it's not the adult orthopedic trauma surgeons that are going to give you a hard time about DVT prophylaxis. Some of the pediatric orthopedic surgeons will, but it's just because they're less familiar and they don't think it matters.
I just would love you to send us when I should not. I just am still wishy-washy on that. I get what you're saying, but when it comes on rounds the next day, the question is, well, but maybe this case is different. Maybe.
So I think if the patient has a real risk of dying from bleeding for whatever reason, you should not give it.
Yeah.
So if you have a head injury that's unstable, that you're maybe going to put an ICP monitor in, they have an ICP monitor, you're wondering if they need to get a cranie or not, you should probably not give it to them.
Grade 5 spleen.
If you have a grade 5 spleen and you're actively transfusing them, you shouldn't give it.
Yeah,
So it's really, but it's about the risk of bleeding, right? Because that's what we're worried about. What we found in most children, they vasoconstrict very well. They're going to stop bleeding. So if they don't have evidence of ongoing bleeding, then you're fine.
Okay. We got 5 minutes left, so we'll rock on through.
Okay, here we go. I did, too, just to bring up, Kenji made a great point at the Western Pediatric Trauma Conference about when a neurosurgeon has actually operated on someone. Mm-hmm. We probably really need to kind of respect that opinion because they were there and saw the bleeding. But in general, we're up here basically telling you guys that we as pediatric trauma surgeons should take more control over these things. These things can be pretty well protocolized in pediatric trauma. So now we're going home, okay? So you were in the hospital, you started Lovenox, the kid's prophylaxed, but he's ready to go home. What are you gonna send him on? Remember, he's in a wheelchair for 6 weeks. Aspirin, Lovenox, Coumadin, some kind of a new generation DOAC.
Silence.
Comments?
So we've translated anyone who needs.
Can you say that again?
So do a lot of liver transplants and then rec shunts and other shunt vascular operations, and we've completely switched over to DOACs. Easier to adapt, easier to kind of manage for family. They don't have to get the coaching for low molecular weight heparin injections and such. It just makes life easy for them.
Is that prophylactic dosing or therapeutic dosing?
Both.
Both.
Would anybody use aspirin?
So this is very interesting. So, about a quarter people are going to go aspirin, and about a quarter people DOAC, and then a lot of Lovenox, right? So I think everybody knows, but the downside to Lovenox is that it is an injection. And this would be totally black diamond and really kind of questioning the group of, is this something that we can get behind? But if you go to the next slide, there was a well-done adult study that was published in the New England Journal of Medicine. And again, this is 100% adult data with adult trauma patients that had orthopedic injuries. So it was a randomized controlled trial where they looked at 6,000 adults and they gave them aspirin, and 6,000 adults and they gave them Lovenox. And what they found is that aspirin was non-inferior to Lovenox in terms of DVT prophylaxis in that patient population. So, if we think about pediatric trauma, we will never get the numbers needed to figure that out in a randomized fashion. But, I'm questioning, I think a lot of us are questioning, in these kids, can we put, they're 16, right? They're 16 years old and have a pelvic fracture. Can we send them home on aspirin, 81 milligrams BID? That's most likely going to be followed way more than these Lovenox shots that we've been doing historically. So, comments?
What dose of aspirin they're using, and some kiddos don't respond to the aspirin same way. So you have to do a platelet aggregation study to really see, if your aspirin is being effective. So
that is probably true when you have a shunt that you want to stay open. Probably not so true when we're looking at DVT prophylaxis for non-ambulatory teenagers.
Great point. So to be provocative, we have started discharging kids on aspirin. Realizing that is, taking some adult data that is not perfect, but it seems effective, and it's a lot better than Lovenox in some of these kids, and a lot better than nothing also, I think.
Yes, we also discharge on aspirin, and our orthopedic surgeon started doing that a year or so ago.
Comments or questions? All right.
All right, we have 2 minutes.
Yeah.
1 minute. This is going to be really fast. 16-year-old shoots herself in the abdomen while cleaning her rifle. She is hypotensive and near arrest despite massive transfusion. What are you going to do? Next step in management. Raise your hand if you're going to do an ED thoracotomy. Okay, nobody. Who's going to do a Reboa? Also nobody. Laparotomy. I got some hands.
A lot of laparotomies.
MTP. Most of the people in the room aren't going to do anything. Let's see what the poll says.
Yeah.
You can. Yes. So 50% would do laparotomy. We have 23 for Reboa and 18 for ED thoracotomy.
That's a lot of Reboa.
That is a lot of Reboa. So Reboa, resuscitative endovascular balloon aortic occlusion. Here's the data. It can be used in children. It's not super effective. We don't do a lot of this in a pediatric hospital, and so to do it very quickly in a patient population that you don't do it in very often is going to be very difficult. But you can do it if you have that at your center and you're very good and facile at it. But the things that you really need to think about for this are 2 things. This is the Western guideline that's a Western PTS and East sponsored that looks at a pediatric emergency resuscitative thoracotomy and when to do it. So this would be the patient to do it if you could not get them to the operating room to actually control the source of bleeding. The second is the adult version of damage control therapy for hypotension and shock. And you can see Reboa is actually under hemorrhage control. And so it is an option, but it depends on what you have available at your center. The most important thing for this child is that you recognize shock and you treat it as quickly as you can in the most controlled environment, which at my hospital would be in the operating room doing a laparotomy.
Have people in the room done Reboa?
Nope. It's real hard to get access if you're not facile with cut down on a dead patient.
Yeah. It seems to me to take longer than opening the abdomen or the chest if you're just needing to cross-clamp the aorta.
All right.
It does show it looks some sort of survival advantage in adults, but also those patients were not as sick if you look at the main trial. So there isn't a clear survival advantage for using Roboa, even on the adult side, so certainly not over to the kid side. Thanks, y'all.
Thank you, everyone.
This was awesome. Thank you. I love this, and in fact, just to show you, when was the Western? July. In July, I was lucky to attend the Western Pediatric Trauma meeting, and there was a conversation about BCVI. Remember, I didn't even know what that stood for. 2 years ago, blunt cerebral vascular injury, and this concept that there's a protocol for knowing when you should be imaging patients for risk of blunt cerebral vascular injury. I didn't know anything about it. Was it a week after 2 kids came in from, this was in Akron, 2 kids came in with a high-speed motor vehicle crash and both had the shoulder strap, bad injury on the skin on their neck. So I texted everyone, I don't know if I copied you and Mira and everyone, I said, so wait, I should be getting, and I followed the protocol. I don't know if everyone has these algorithms, but it was amazing how a week after I put it right into practice and those kids got better care because of your conference, so thank you. All right, we're going to move right on to cryoablation. We have a diverse crew here from different hospitals. So we got John DiFiore from the Cleveland Clinic. Tim's up here again for like you're the expert in every topic. You are the absolute general surgeon, man. It's like, and Tom Inge, both of these guys are from Lurie Children. So take it away.
All right, great. Next slide. Actually, this slide coincides with actually a green, a blue, and a black. So we'll see if we can get through it. We have 2 10-minute presentations here, so we'll see how we can do. I'm trying to find out from the international audience how many people are using cryo, because that's not clear. It's becoming pretty quickly the standard of care in the States and in other places, but I'm curious to see just what our audience is. That might affect where we go with the talk too, depending on if people are new to it or not using it yet. So, okay, so 30% have never used it, and some on select cases have never used it but want to start. So that's quite a bit. So about 50% have never used it. Okay, that's very helpful. Let's have the next slide. I'm going to basically go quickly through our technique at the clinic. We use a double lumen tube in all patients. Our freeze point is in the posterior axillary line, about 4 centimeters from the vertebral column. With the original cryoprobe, we're going to talk about some newer options. It's a 2-minute freeze cycle. We go from T3 to T8, although most of the literature is just to T7. After cryo, we do intercostal nerve blocks with subpleural injections. That's kind of the blue portion of the talk. If you can go to the next slide and start the video. This is on the left side of the chest. And one important landmark up top, you can see the subclavian artery going over the top of the first rib. That's your landmark to count. So that's first. We are doing cryoablation on the 3rd rib. Again, just where that muscle starts to begin is a good landmark. And 2-minute freeze cycle, and then you just work your way down from the 3rd to the 7th rib. Next slide. You can play this video. If you play, there we go. So after we do that, I also do a subpleural injection with 0.25% Marcaine with epinephrine. This works immediately as opposed to the 8 to 10 hour delay with the cryo nerve block. This is very simple to do. It takes about 15 seconds per interspace. That's a 25 gauge needle. It's actually a urological needle, and if anybody's interested, I can show you exactly the number to do that. But you can see the exposure that we get from the double lumen endotracheal tube, which is quite exceptional. Next slide.
John, you like that better than percutaneous needle?
Yeah, absolutely. I think it's very quick to do, and it's very easy to do, and you know that you're getting it right on the nerve. So if you have never used cryo, and that's about 50% of our audience, what is the main reason? Cost, takes too long, concern for chronic nerve pain, or some other reasons?
A lot of others, which is probably equipment availability, I would imagine.
Okay. All right. Okay, very good. So that's a good answer. I was expecting that a lot of people hesitate just because of the time involved, so I'm going to talk just very briefly about that for people who are already using cryo. There is a new probe that's available that cuts down the time significantly. Doing T3 to T8 bilaterally, it saves almost 30 minutes. So the tip now gets down to temperature about 20 seconds faster. The freeze cycle is 90 seconds instead of 2 minutes. It's 15 seconds less to thaw back to the temperature. There's also improvement on the shaft insulation, so it can actually touch the lung because it only gets to room temperature. That's particularly important for people who are not using a double lumen tube, where they're crossing the mediastinum and maybe have the lung as more of an issue. The shaft is also stiffer, so it's actually a lot easier to place. Next slide. So on top is the old probe, and the bottom is the new probe. They look different, and there's different insulation on the shaft, and the temperatures are different, as you can see. So that is available. Why don't we skip this, because we're only talking with, let's keep moving. Let's go through that and skip that. I just want to highlight one paper, go back to that one. One paper by Seth Goldstein's group in Chicago, where they did do a 1-minute freeze cycle instead of a 2-minute freeze cycle, and they had nerve blocks that were just as effective. A little bit of a limited study because they didn't actually measure pain scores or compare it directly to 2 minutes, but that is something
I've seen it with my own eyes.
Okay, yeah, and I think Tim's going to talk about that. But with the new probe, it's only a 90-second freeze, and there's actually another new probe that is 10 millimeters in size that is a 60-second freeze that gets down quicker with a larger ice ball. That's coming out on October 1st. So the options aren't, you're not really going to have to compromise your time in terms of the amount of freezing that you do. Next slide. So this is a bit of a source of debate is whether or not to use a double lumen tube or not. I use it in all cases. You saw the exposure of the intercostal nerves is really exceptional, and it ensures that you're applying it posterior enough so you get the lateral cutaneous branch, and I'm going to show you a diagram. What I've noticed, and I've gotten multiple calls from other surgeons, go back one please, multiple calls from other surgeons that say, well, you know, sometimes my blocks don't work, and invariably it's been a surgeon using a single lumen tube and doing the block too far anteriorly because they can't get posterior to that anterior axillary line. So next slide. We're really trying to make sure that we cover that lateral cutaneous branch. Next slide. Dr. Kim from UCSF did the beautiful cadaver study showing that actually 18% of the nerve of the lateral cutaneous branch are posterior to the mid-axillary line. So if you don't get posterior enough, that's when you get blocks that are ineffective. So I think that a double lumen tube greatly facilitates that. A lot of groups have success with a single lumen tube, doing the mediastinal dissection, going across from the right side to the left side. Next slide. I'm interested to see who uses a double lumen tube and who uses a single lumen tube.
Hey John, quick question. So I haven't done one of these in 4 or 5 years, but I used to do a lot, and I never did the subpleural injection, and our results were quite good. I mean, it didn't seem like we have to wait 8 or 10 hours for it to work. So was I just lucky, or?
No, I think you can certainly do it without that. There's a few advantages that I have in an upcoming slide, but our anesthesiologists use 0 opioid in the OR. Basically, they run anesthetic gas and propofol, and that's it. And there's a lot of strong anesthesia literature showing that the less opioid you use in the operating room, the less you use post-op. So our study has a very short length of stay, 1.1 days, and some of the least opioids available in terms of post-op use. What's the result there? So half and half. Okay. Next slide. I have 2 minutes, so I'm actually going to, I want to jump to keep going. Again, I want to get to the black topic. Okay, the black diamond. So Dr. Kim, again, this cadaver, what he also showed in the study was that there is a large collateral branch of the intercostal nerve that runs along the top of the nerve, separate from the main intercostal branch on the bottom of the nerve. So what he did in a small series of patients was cryoablate the main intercostal nerve on the bottom and also the top of the nerve below it. Next slide. And this is what that looks like. I've started doing this. I've done this in about 20 patients now. And you can play that video. In Dr. Kim's study, he had patients going home in 1 day instead of 2. But this is the standard location for freezing the nerve. And if you just go to the top of the rib below it, now there's not enough room to put them immediately under each other until you get further down in the chest. And I'm going to show you, as you move down toward T7 and T8, the interspace will widen enough. So on the next freeze cycle, you're going to see that you can do it immediately below the standard freeze. So anecdotally, I've done this in about 20 patients. I would say the average pain scores, the peak pain scores have dropped from about 5 to about 3. It hasn't affected our length of stay because 98% of our patients go home the next day anyway. In Dr. Kim's study, his length of stay went from 2 days to 1 day. But what impressed me was that he had 9 out of his 22 patients reported pain scores of 0, which I thought was impressive, which is why I'm trying that. Again, this is not a sanctioned use of that. Todd told me to make sure I say that. It's kind of a new thing, but it's very easy to do. Of course, now the probe takes half the amount of time, and now I'm doing double the number of blocks. So it kind of washed out the time effect there. But actually, you can stop there. I think that's all the time we have.
Any questions before we go on to the next section? Awesome. Thanks.
Okay.
And now we're going to kind of pivot into non-pectus uses of cryo. And so we can move on. And so we're going to talk about some of the basics, which we've already covered a little bit. Some of the benefits in thoracotomy, which is what I, as a surgical oncologist, use this most commonly as. And then talk about some novel uses, especially if you start to use percutaneous applications of cryo. So we can go on. So just as a reminder, some of the basics, is that you do want to stay far enough posterior, but you also want to stay off of the sympathetic chain. So you can, certainly during thoracotomies, you can visualize this very clearly. So I try to get about 3 to 4 centimeters away from that. And remember, what's going on here is you're getting axonal degeneration by the freeze, but at the same time, the epineurium is staying intact, and that's what allows for the regeneration that occurs. I don't think we need to talk about the pectus, category, because that's really the paradigm, and we've already covered that. But really, as we go on to the next slide, we can talk about, I think we skipped a slide, but when we're doing a thoracotomy, what are people doing for their postoperative pain control after not a neonatal thoracotomy, but a metastectomy for osteosarcoma or something like that? We can go to the poll now. So what are people doing for that? A lot of epidurals, some paravertebrals, some IV pain meds, not a lot of cryo. I'm hoping I can, making a comeback. I'm hoping I can convince you that cryo is a really good tool here, right? Epidurals are wonderful, but it is an invasive procedure that, at least at our institution, takes a little bit of time, and you may or may not be leaving a Foley. And it really only gets them through those first couple of days, whereas, as we know from pectus, the cryo is getting you all through the recovery period. So there have now been 3 pretty good publications about using this for metastectomy thoracotomies. When we're doing it, it's just right through the, we're doing a muscle-sparing thoracotomy, and then just doing an open direct application of the cryoprobe. We have been doing 60 seconds for all of our cryo, both pectus and non-pectus. We've done like 300 AtriCure cases, all at 60 seconds, and really seeing great results. So you can really cut down the time. We're going 1 to 2 levels above and below the thoracotomy. You do have to be a little bit careful about getting too low, which shouldn't, you're not usually doing a low thoracotomy, but once you get to a T10 or lower, you can start to get some pseudo hernias on the abdominal wall just from affecting the motor branches there. Like I said, 60 seconds is sufficient. We also do temporary intercostal nerve blocks to help for those first 8 hours before it kind of sets in. We're using the standard probe down to about age 3, and we've done kids down to about 18 months. There's a cardiac probe that they use for some of their ablations that you can use as like a smaller probe if you're doing smaller kids. But in smaller kids, you do have to be really careful. We like to get a retractor in and hold the skin away because there's not a lot of chest wall musculature and you could get some skin freeze.
So Tim, that with the new probe, that problem is totally eliminated because the shaft insulation only gets to room temperature. So you can touch the lung, you can touch the skin. The only thing that gets cold is the probe. So you should check it out.
The benefits that we see is there's no epidural, there's no Foley, they're getting up and moving right away. Their pulmonary toilet has been great. We did a comparison in our group and we saw a 2 to 3-fold reduction in narcotic use during the hospitalization, basically sending these kids home without narcotic prescriptions. And for me, the best benefit is no waiting for my regional team. So as this was our data. And so, we compared what their results were, both compared to all of the routine group, which was some just IV pain med only, but also compared to those that had regional block. And so, in this study, we had 23 thoracotomies who had cryo. And even if you look at the oral morphine equivalents during the stay compared to those who had regionals, it was way dramatically lower. So 137 versus 533. So we're using a lot less opioid. And so this is routine for us now. Other than our neonatal thoracotomies, we've really gone to using this all the time. Now we're going to talk a little bit about, besides just the standard cryoprobe, once you start, again, going back to the OR-IR collaboration, once you start using the tools that the IR folks have available, which include some of these percutaneous needle options, what else you can do?
Yeah, absolutely. Going to pivot here to some stuff that's right up John's wheelhouse here in IR. Next slide.
Next slide.
Yeah, so we've also seen some real benefits of cryo treatment, cryoablation for rib fractures, but also slipping rib syndrome and other endochondromas, as you see here. Slipping rib syndrome, anybody raise your hands that have seen this before, taking care of these patients? A few in the audience, yeah, most actually. So this is a condition with cartilaginous union at the end of our ribs, for our floating ribs in particular, but also, of course, we've got false ribs that are higher up that we see sometimes a laxity in some of these costochondral junctions, and we can see the impingement on these intercostal nerves, either the ones that are the largest, which are the inferior, or even superior, as the ribs do slip and float and actually encroach upon these nerves. So there's conservative management, and we've all seen patients that come to us with their appy already out, maybe even their gallbladder out, and nobody has arrived at the right diagnosis. A lot of colonoscopies and CTs and ultrasounds, but slipping rib syndrome can be the cause of chronic abdominal wall pain, and they can end up in your clinic for what next. So always assess for it, and when we find these patients, typically they are teenage girls, more so than boys. When we find them, what we find is that they'll often have this somatic tenderness of the abdominal wall, but they really won't have visceral type tenderness. So in other words, you can get them to do a crunch or flex their abdominal walls muscles, and then you palpate, and you can get actually more tenderness when they're crunching than when they're relaxing. So that's a tip off. Back one slide, sorry. Slides are getting ahead of me. And so what we actually do with these patients with the slipping rib syndrome in particular is that we will make the diagnosis. Again, often we'll have some incisional scars and a normal API on pathology, but then refer them to chronic pain. And so chronic pain can do an evaluation, also elicit the same kinds of physical exam findings, directing them to a slipping rib, and do an intercostal block, usually a steroid as well as a long-acting local. And you can actually determine whether this is the cause or not, because it's a pretty diagnostic test. Once that's done, it might last for a while. It could last for weeks. It could last for months. It may only last for days. It depends. These patients are somewhat heterogeneous. But if there's an actual response, the next step that would be reasonable is sometimes to go ahead and refer to surgery, or to take them on as a surgical patient. Sometimes patients want to know, is there an in-between? And that's where more commonly these days, especially now that there are these needle probes for the cryo, our IR folks are actually doing a ablation. They may do an ablation actually at at just the right level, or they more commonly are doing multiple levels. And then what we've had a number of these patients. This is actually an intra-operative photo, X-ray rather, of them doing their needle probe placements and freeze thaw cycles. So next slide. This is actually a paper from some of our friends in Phoenix. I don't know if there's anybody from Phoenix here today, but maybe in the audience. And what they found is that when they're doing surgery, actually for slipping rib syndrome, they will also use cryoablation intraoperatively. So kind of a marriage of the surgery to remove the rib tips or to stabilize a slipping cartilaginous costal margin. And then also use cryo for the ablation at the same time. So you find shorter length of stay, lesser narcotic use. So 2 minutes coming up on this. We can also, and I think you may have been the trauma surgeon on call for this patient, right? I think I picked him up afterwards. But basically, if you have someone come in with just a terribly flail chest or fractures that get stuck on a ventilator, actually you can do a world of good with this technique as well by anesthetizing just those ribs that are intercostal spaces, that is, that are the problem. Get the patients off the ventilator, pulmonary toilet. You anything else to add?
No, and I would just remind her there's multiple ways to apply this tool, right? So we're used to doing it with the standard probe from the intrathoracic approach. You know, one of our partners did one of these slipping rib cases yesterday. He did a plating, and then you can do this external application of the cryo right there in the OR, or you can refer to the IR colleagues who are using these same needles for cryoablating liver lesions and lung nodules and other things like that. And it's just a different application of the tools that they have in their armamentarium. And so
you can get one poll question or one more.
Moving on. So what else can people, we're doing these open-ended questions. What other tools, what other uses of cryo are people doing?
Maybe we'll skip the poll, but then talk about
actually, it's not a poll. This is just a panel question. So.
Oh, great. Okay. Yeah.
Any other uses?
I have a question. So I've got a child that's out there that's
hold on.
Pectus carinatum, right? And bad pectus carinatum. I think psychosocially a fairly put together kid and family. I talked to John about this the other day. Potentially just moving forward with cryo alone, not wanting to commit to a full ravage or anything like that. But my question is, particularly, you may have experienced this with the pulmonary metastatectomy. Can you go back and do cryo again and again? Because I would want to do that for the ravage eventually, but be very nervous that would create some sort of neuroma or something bad.
No, I've done this with at least 2 patients with osteochondromas that were fairly symptomatic, and we did it first, and then when we went and did the rib resection for osteochondroma, we re-cryoed, and they did just fine with it.
Yeah, and I'll be able to tell you a little bit more about that too, because the same patient, one of these patients that our folks did, is coming up for me to take care of this week, actually. And the question was, should they do another cryo? Because she got 8 months out of the original cryo. And in fact, they asked the question of, well, can you just do an ablation, a complete ablation with phenol or alcohol? And that didn't seem like a really good approach. But I'm going to use cryo when I actually operate as well, so we'll be able to see.
Yeah, in terms of novel uses, I actually have a patient tomorrow. What you'll find is when you start to use cryo more and more, you get patients like this one, a 16-year-old teenager with just this very unusual left-sided chest pain, came from an outside institution, a huge workup, they can't find anything. And honestly, I'm not sure what it is. There's no chest wall anomaly, but we're going to do just transcutaneous intercostal nerve blocks as a diagnostic tool. And if that works, we'll probably go to cryoablation. Now, I was going to do it transhoracically, but I might talk to you, Tom, about having them do it percutaneously.
Yeah, absolutely, we can connect.
Because it's one of these techniques that you start to find more applications for it the more you use it. And there's a lot of very strong literature in the adult trauma literature about using it for rib fractures. And if you ask the cryo reps, that's where the vast majority of their calls are from, that they'll go into the OR for rib fractures with cryo and plating and things. And there's a lot of data on
Your cardiac
pulmonary
surgeons might be
recovery.
starting to use it too. I mean, it works for sternotomy pain too. We don't think about it as much, but it works great for that too.
This is awesome. I mean, it's a great tool that we can start finding tons of that. Thanks, guys. This is great. Thank you very much. All right. We got two presentations here that are totally unrelated to each other, but very important, so we put them together. First we have, so Mac Harmon from Oshai Children's in Buffalo is moderating this, has been doing this with us since the beginning of the update course, so thanks, Mac. We have Dr. Greg Tiao, who is one of my 5 bosses, who is the director of pediatric surgery at Cincinnati Children's. And we have Dr. Gloria Coca Gonzalez, who is moving now soon to the Cleveland Clinic, coming from Santiago, Chile at Calvo McKenna Children's Hospital. So take it away, guys. Thank you.
Well, thanks for having me here, and it's a privilege to serve as Todd's pseudo-boss. He really doesn't have a boss. He just does a lot of different things at Children's. But it is a privilege. What's that? Well, we're trying to minimize this, but we are going to ask Todd that question right off the bat. What's a matrix metalloproteinase? But he already said at the beginning that he has no interest in proteins and things along that line. But in the next few minutes, I'm just going to touch on a couple of things that are relevant for biliary atresia, a disease that I have a fair amount of interest in. And what we're going to try to touch on is a concept that I think we're all quite familiar with, which is a timely diagnosis of biliary atresia is critical to prolong the native liver survival. And the challenge, of course, is we all face is that oftentimes these kids come in late, they take a little bit of time to work up, and so the end result is we're offering surgery at later and later dates. And so the key for biliary atresia is to establish an early diagnosis. And this is where this biomarker that really came out of Georgie Becerra's lab, my research mentor, he identified about 10 or so years ago in terms of it as being a diagnostic biomarker for biliary atresia. And this all ties to this critical concept that I think we all know, but we don't necessarily integrate, which is you gotta get your Kasai's done as soon as possible. And the tradition, I think, when I was going through training was you get it done by 60-odd days, you're probably okay. But the curve has really moved as data has come out showing that the sooner and sooner you get it done, the more likely you'll save the native liver. And so this all goes to a scenario where you want to establish the diagnosis as quickly as possible. So this actually was a little guy who showed up just a couple of weeks ago on our service here. It was a 38-day-old child. So again, pretty standard, right? Has a little bit of jaundice, passed meconium on the first day. He's gaining weight, so doing all kinds of good stuff, but he's noted to be jaundiced. Pediatrician says, oh, it's physiologic jaundice of a newborn, but then it persists. So this is when things start to get triggered. His stool, in this case, was pretty clay-colored. I have some of the labs there in which it's pretty classic for biliary atresia. And so, again, this is the diagnosis or the conditions that our pediatricians are facing. We then refer them into a hepatologist who then starts a workup. And of course, as we all would want, they'll get an ultrasound here, and in this particular case, it had pretty classic findings for biliary atresia. But the challenge that our pediatricians face is the differential diagnosis for neonatal jaundice is pretty long. And there are a couple of conditions in that grouping that we don't want to do a Kasai for. You do a Kasai for an Alagille's, you do a Kasai for a PFIC, you just converted that patient to needing liver transplant before they're a couple years of age. And so this is what the pediatricians are facing in terms of a workup. These are the standard conditions that they're dealing with. But what they're really looking for is a diagnostic tool that is sensitive, specific, and improves our efficiency. Then there's a whole series of things that people will end up doing during that workup, and we're going to touch on them in a second here. But the key is to distinguish BA from other non-physiologic cholestatic jaundice conditions so that we can get our Kasais done at an earlier and earlier stage. Next slide. So this was the first audience poll. So we have a patient like this. You have an ultrasound that's suspicious for it. What are you going to do? And so this is where I listed a couple of different options, and we'll see how people respond. But I don't know how many people in the audience are doing the Kasais. I think more and more institutions are having focused people do them, but it's kind of an evolving topic. That, again, is a volume outcomes question, but are there any of the participants here doing Kasais? Bhargava left, so I know he was doing them in Kansas City. But so, for those of us who are doing Kasais, what is your decision making here? So we can go to the response. All of those options are actually correct because it depends on your institution, right? At our institution, we stopped doing HIDA scans. We stopped doing HIDA scans about 25 years ago. And the actual NASPGHAN guidelines for workup for cholestatic jaundice is not to do a HIDA scan. But there continue to be papers coming out showing that there have a value in some institutions. The challenge that we face with a HIDA scan is it adds about 5 days to the study. And there's some data that's coming out from a Midwest study where every 10 days that you delay a Kasai translates to 20% worse outcomes. And so all of this translates to biliary atresia is a strange disease process. As a person who's been focused on this for 20 years and has had funding for it all those years, I still have no idea why the diagnosis even arises or the condition occurs. But it is one of those things where the earlier we can intervene, the better off we'll be. And so this translates to some work that led to this MMP7 study. But all those other options, a liver biopsy, some institutions will do. Some institutions will take them to the OR, do a diagnostic laparoscopy, a liver biopsy, a cholangiogram, and then decide on the Kasai. Some institutions will just do an XLAP, cholangiogram, Kasai. So all of those are different things. But the trickiest patient population, when you go that route without having a clear diagnosis of biliary atresia beforehand, is Alagille's. And every year, every pediatric transplant program is dealing with an Alagille's kid who got a Kasai done. We've done it ourselves because that cholangiogram is really, really difficult to differentiate from biliary atresia because those ducts are hypoplastic and it becomes really difficult to distinguish if there really is anything going into the liver. And so this is still where our pediatricians and hepatologists face this challenge, which is if they can help us figure out biliary atresia beforehand, it'll make our decision-making so much easier. So about 10 years ago, Georgie took on some data from the Children's Network. And for those of you guys who are not familiar with it, Children's Network is a national consortium of about 14 centers in which all the cholestatic liver disease children were enrolled in the study. It was enrolled in the registry. And he took about 70 or so patients from that, some who had biliary atresia, some who had cholestasis, idiopathic cholestasis, and did proteomics on that. And he screened about 1,000 proteins, and they actually found 70 or so that were elevated in the BA population, of which MMP7 was the most clear. And so this is the data on the next slide. Actually, jump by it. Back. Can we go back another slide? Yeah, one more slide. So this is the, one more slide. So this is the discovery cohort where he looked at 35 patients with biliary atresia, 35 patients with cholestatic disease, not biliary atresia, and he looked at outcomes and he looked at GGT and MMP7 as being the two that most predicted biliary atresia in terms of a diagnosis. Now the challenge that he faced is that when you look at the disease frequency, even in the Children's Network, you're only seeing 200-300 kids a year. So to do another study to validate this was very difficult. Well, this is where he took advantage of the incidence being higher in the Far East. Next slide. And this is where he actually validated it in just 2 years in a study that was done in the mainland China, where the frequency of biliary atresia is much higher. And of course, they really strive to get those kids a Kasai very early, because if they don't, living donor liver transplant is their only option, and it's not readily available. And so those kids face a mortality risk. And so what they did is they validated this study through a series of efforts to really show that MMP7 is a diagnostic biomarker for biliary atresia. And this is really where it's now being integrated into the algorithm for workup. There have been a couple of other series that demonstrated the same predictive nature of it, done in a variety of different countries. So MMP7 is here. It is now a validated biomarker for biliary atresia. It's not perfect. And actually, if you just look on the table here, the sensitivity is pretty good, but the cutoffs that the different teams used varied, because it's an assay that's still evolving in front of our eyes, and depending on how you do it, if it's in blood spots, and if it's actually in ELISA on the blood, it's all stuff that people are working out. But this all translates to this then next question here, which is, when are you going to do your Kasai?
So we got 2 minutes left, so I would maybe go quick on the poll and then just give
And again, all of these answers are understandable and acceptable. But what you actually have to integrate into your whole process is, you get this diagnosis. This is not, oh, I'll get them scheduled in a week or 2 weeks. We put these kids, our commitment to the patients who come to our institution is within 7 days of them showing up. If they have it, they're in the OR. And this is where we've moved our dial. Now the next slide is just a study from the Children's Network, in which Rick Superino looked at the registry through like 2010, in which they showed that the average date of a biliary atresia patient going through a Kasai in North America was around 75 days. But then there's been a whole series of other national registries. Next slide. This one came from Europe, where they actually showed that if you did your Kasai before 45 days, you'd actually reduce the incidence of transplant need in that patient population. And so all of this is moving the dial to integration of MMP7 into your workup, so you make the diagnosis at an earlier age, so that you get these patients on to a Kasai if possible. And this is really the last point, which is a Kasai portorostomy done before 45 days is the goal. We actually will do it before 30 days if we can establish the diagnosis, because nowadays more and more nurseries are screening their kids at discharge. And if you have a total bilirubin, a direct bilirubin over 1 in the newborn period, that's also very sensitive for biliary atresia. So those kids get plugged into GI teams sooner and sooner. So we're actually seeing our Kasai in timing going from 50, 60 days to now we're shooting for 40 days as from a programmatic standpoint. The 20-day-old Kasai is anxiety-provoking, because you're doing a JJ and a tiny little kid, and you actually have to start thinking about putting him in the ICU for monitoring afterwards. But we are pushing to do these Kasais as soon as we can, because we think it really makes a difference. And all of this goes to my end goal, which is put ourselves out of the transplant business.
That's awesome, Greg.
Thank you, Greg.
Amazing. I'm just curious, who is sending out MMP7s here? Where do you send it? That's what I was going to ask you.
So therein is a dilemma. So Georgie, when he established it, had it in Cincinnati. Then he went to UT Southwestern as a chair. They took it. But now more and more hospitals are putting MMP7 into their standard ELISA assays, because it actually has value not just for biliary atresia, but it actually has rheumatoid arthritis. There's other conditions in which MMP7 actually has a diagnostic indication. And so it's an evolving process. We're trying to operationalize this in the Midwest Pediatric Surgery Consortium in the sense of trying to do it prospectively to get all the patients' blood sent to a center that has it. Cincinnati is, our team's putting it back online in the next few months.
So Greg, people are, like in the chat, people are going to want to know. I mean, we started sending it out in Akron. I don't know where we send it now, I guess down to Georgia.
They all go down to Georgia right now, but in UT Southwestern. But it's a bioassay that can easily be, ELISA that can easily be done across the board. And this is where you actually have to know how the assay and the actual assay values are. There are some assays which, if you look in the Far East, they had a 2.5 nanograms per ml as being elevated. In North America, in Georgie's assay right now, it's 18. When it was in Cincinnati, it was 50. So this is where the assay is still being integrated into the workup in a way that's going to be useful.
Yeah, it's game changing. That's why I was really glad we're talking about this, because I was behind the times, but I know that we're catching up. All right, thank you, Greg. That was awesome.
Fantastic.
Hello, I'm Gloria from Chile, coming to Memphis. So I'm going to talk about an old update, because this is a technique that is used in adults, and I bring it to the children. And I'm talking about lipiodol in meds. So why we're talking about this, osteosarcoma specifically, they have like till 50% of the patients have lung meds. So during their disease, in many cases, they have only 2 or 1 nodule. So what we are going to do with that, go ahead. Surgery can improve survival, we know that. We know that we have to take out all those nodules. And if we have 1 or 2, we can do it minimal invasive, because we know what about minimal invasive versus thoracotomy. Go ahead. So first, if you want to take a nodule for like minimal invasive, it's a 1 centimeter nodule. What's the rate of conversion due to failure to localize subdural nodules during thoracoscopy? And that's the first pool. So what do you guess? So yes, what's the answer? It's 47%. So the conversion rate is really high. And you say, well, 1 centimeter, I'm going to see it, I'm going to look at it. And if you don't, or you can get a double tube in there, it's much higher. So what we are doing now. So pre-op localization techniques, we talk about that in the radiology intervention section. We can do many things with radiology. Localization with imaging during thoracoscopy, meaning ultrasound, or fluoroscopy like CT guidance. Preoperative location techniques like dyes, like methylene blue, contrast medias, radionuclide, adhesive color rod, many things, or hook wire placement. Go ahead. That's the second question. Which one are you using now? So today we talk about, and I heard somebody from the audience that they use wires, methylene blue, indocyanine green. Those were some of the questions, no? Can you see the answer? Okay, thank you. So none is 47%, and injection dyes, blah, blah, blah. Okay, go ahead. Why I don't want to use thoracoscopy images? CT, you're exposing the patient for radiation all the time. Ultrasound is difficult performing the ultrasound when you have really small nodules. If you have one nodule like 2 or 3 centimeters, you are not going to see it. And in case of the osteosarcoma, the calcified lesions, they're really difficult to see. So there's no using for that. Why not hook wire? Why I don't like it? Dislodgement. The rate reported for dislodgement is 2.4 to 22%. And in my case, because I don't have the CT in my OR, the patients have to go to the CT scan, under anesthesia, and go to the OR. And in that case, the dislodgement is much higher. And when you put the pneumothorax, the wire, again, is dislodged. So you say, well, we can do blue, methylene blue, you know, with the wire, so I can see both things. Go ahead. And we have seen methylene blue all over the chest, but not in the nodules too many times. And what about ICG? It's a really good option, but if you have a deeper nodule, like 2 centimeters deeper nodule, you cannot use ICG. So yes, it is a really good option for really subpleural lesions, bigger than 5 millimeters, but I cannot use it in all the cases. So what I'm doing, lipiodol. Go ahead. So the marking procedure is under CT. Those are the radiologists interventional doing this. So they mark the nodule with lipiodol. That is an oleous oil dye. So it stays in there like 3 months. So I don't do the surgery the same day. If I if I can't, for example, I can do it like 1 week ago, 1 week later, I'm sorry. Go ahead. And this is the setting in the OR. I put the C-arc under the patient, put the laparoscope. So there is always some hematoma or something in the surface, and I'm looking at the images in the radioscopy, put the stapler on, check it under the C-arc. If I got the spot, the lipidol spot, fire my stapler, and take it out. With this technique, you can go ahead. Well, after I do the palpation for the tissue, and I know verifying the radioscopy palpation, and after that, doing a radioscopy of the lung that I don't have any lipidol left in the lung, so I know we have the nodule that we went for. So what we have done now is 33 nodules, patients, We have 3 or 4 nodules, until 3 or 4 nodules per patient, if I want to. And there's not osteosarcomas, not all of them are osteosarcoma. We have a joint sarcoma, Wilms, infectious disease, like many histologies. And we have done, like I said, 50 nodules, something like that, with 100% sensitivity. So now the last question. Would you consider changing your practice?
I love that you put this question in while it's coming. This is a classic Mac Harmon question that you always need to put this question at the end of your presentation to see. Go back to that. Go back to the poll, sorry. Look at that. That's pretty incredible. That's
Really
not
good.
even subtle. So that's awesome. John, Amanda, do you guys have comments on this?
No, that's an awesome presentation. Thank you. I know in our research lab one time, Dan Von Allman and I, we tried some Lipiodol. Again, I don't think we had the proper technique. For us, the Lipiodol, wasn't kind of staying in the focal area for during that procedure, but it sounds like it stays there for many days and even a couple weeks. Yeah, you mixed it with glue. I think one thing, the key with the wire technique is when the lung is being deflated, right? So what we do is we'll actually sometimes actively kind of push the wire in as the lung is going down, or cut it at the skin surface, and the surgeons, when they get their scope in there, without having the lung come down very much, they actually help pull it in through the chest wall. I know Tim mentioned actually leaving a little micropuncture set so that wire it's not the friction of the chest, it actually slides through the micropuncture set. I thought that was a great technique. Yeah, and it does help. Have it in the hybrid where we don't have that transfer. There was one patient that actually came up. We used to do them in CT. We would build up gauze. We put Dixie cup things over it to kind of protect it. But there's one case that the patient got up to the OR, and during the prepping of the patient, one of the nurses what is this? And actually yanked it out. So that happens too.
I think this is a great example of just find the techniques that works for you and your institution. A lot of people have had success with the wire. I don't love the wire, but I think what you're doing with Lipiodol is very similar to what we do with coils and what other people do with fiducials, which is to have something that just goes next to the nodule and can't be dislodged, and then you use fluoro to find it.
Yeah, I want to ask you that about the coil, because there is a problem with the sample, kind of the results, the histology. It might be difficult with the coil, put it in there. So how do they manage the specimen?
I do warn the pathologist when they're getting ready to slice it that you're going to find a piece of metal in there somewhere, but they're so small that they haven't had trouble with it. Yeah.
So this was a phenomenal session, and I just decided that I'll need help, Em and Cecilia, but after this event, there's so many new things that were just presented today. We still have a few more. I want to make sure we do better on executing from this event today to practice, and I think there's a missing component of access to all of you guys to say, all right, we are ready to start this. Please point me in the direction on actually how to start, because it's a great idea. We go back to our practice. So maybe what we'll do is go through all the things with a contact of someone you could reach out to say, hey, we want to start MMP7. Please tell us what to even begin to do. We want to do we'll do that. This was phenomenal. These are very provocative. Thank you guys for updating us. So we're going to take, it was going to be a 15-minute break. We're going to make it 5, get us close to time, and we'll come right back on what I love talking about, artificial intelligence. Yeah.
Hi, I'm Todd Ponsky, founder of GlobalCast MD, and today I want to talk to you about a significant challenge that every clinician faces. Keeping up with the rapid pace of new research. Every day, new studies are published, new techniques are developed, and new guidelines are released. This makes it nearly impossible to stay current with the best practices for treating patients. And not only is it becoming increasingly difficult to keep up with new ways of treating patients, the number of sources of where this content lives is also growing. How can clinicians ensure that they are providing the best care when the information is scattered across so many sources? Now there's podcasts, videos, hospital guidelines, national protocols, society websites, and more. This overwhelming amount of new information, combined with the disparities of how patient care is approached worldwide, means that clinicians often struggle to find the right guidelines or clinical tools at the right time. Another problem is that organizations who have rotating staff, such as residents and nurses, may not be familiar with the standard practices of their current hospital, so you have everyone treating patients differently. Also, when a clinician is at the bedside, they may not have immediate access to the right resources they need. That is why we developed Stay Current. It's a mobile file cabinet in your pocket, designed to aggregate and curate all the best, most up-to-date information in an easy-to-use format. Whether you're looking for current treatment recommendations, quick video refreshers, technique videos, or even the latest journal articles, Stay Current has it all. Now let's take a closer look inside the Stay Current space.
I'm Isla Senjik, and I'm excited to walk you through the key features of our app, designed to help you stay informed, up-to-date, and connected in your practice. Let's dive into one of the most powerful features of Stay Current MD, our spaces. These are customized private spaces within the app in which hospitals or departments can keep collections of their most current, up-to-date practice tools and educational tools for given conditions, such as guidelines, protocols, background summaries, technique videos, handbooks, and more. After a space is designed and tailored to meet the needs of a specialty, it's managed by a designated content manager from the institution. Spaces can be configured in 3 ways. Public, where they are accessible to all 16,000 plus Stay Current MD users. Private, requiring approval from the content manager to access. Or a blend of both, where some content is public and the rest remains restricted.
This app ensures that everyone in your hospital, from the most seasoned physician to the newest resident, has access to the most updated information right at their fingertips. It promotes better guideline adherence and ultimately better patient care.
Let's look at how the Pediatric Surgery Group at Cincinnati Children's Hospital Medical Center designed their space. Stay Current MD aggregates educational and clinical tools into easily navigatable sections. This group chose to categorize their content in a way that suits their specific needs. Here, you can find trauma guidelines, which are critical for quick reference during emergencies. The resident handbook is conveniently located here, providing easy access to essential information for new team members. Clinical tools are organized in this section, offering a range of resources from checklists to procedural videos. This tailored approach ensures that all necessary information is available in one place, enhancing the efficiency and effectiveness of the surgical team. Stay Current MD also excels at organizing content into disease-based playlists called collections. For instance, if you're dealing with neuroblastoma, you can quickly access a collection that includes everything from the latest surgical techniques to post-operative care guidelines. This curated content is updated regularly, ensuring that you always have the most current information at your fingertips. At the enterprise level, Stay Current MD offers a hub space, which serves as a comprehensive resource for each institution. Think of the hub space as an umbrella that houses all institution specialties under one roof, fostering collaboration and consistency across departments.
One of the most powerful features of Stay Current is the ability for hospitals to share their incredible libraries of content that they have curated with other hospitals in a gated and controlled way. Hospitals can allow others to access very specific pieces of content within their Stay Current space. This means that one hospital can see how another leading institution is treating patients and even adopt their protocols. These customizable spaces allow you to create a personalized, aggregated list of the best clinical tools tailored to your needs.
Our search feature is powered by Elasticsearch, offering a robust and comprehensive search experience. You can search for content across the entire app or within specific spaces, making it easy to find exactly what you need and when you need it. You can share content with a colleague via text or email, favorite important resources, or download videos for offline viewing. For institutions that need a hand in creating content, we can help with that too. Another essential feature of our spaces is the key analytics data we provide. Each space is monitored to ensure it remains up to date and relevant to its users. This data allows content managers to see which content is being accessed most frequently and helps institutions optimize their spaces to meet the evolving needs of their team. Stay Current MD is designed to keep you connected with your colleagues and the latest medical knowledge, no matter where you are.
With Stay Current, staying on top of the latest in patient care has never been easier. Let's ensure that every clinician, no matter where they live or where they work, has access to the best information when they need it the most. And with the ability to share curated content between hospitals, we can all learn from each other to provide the best care possible. Thank you for watching, and I look forward to seeing how Stay Current can help you enhance your patient care.
Today, Children's Mercy is writing a compelling story for the future. What we are doing is strategic, fresh, new, and innovative.
Our mission is to create a world of well-being for all children. That really resonates with me and drives what I do every day.
We continue to reach new highs in every area, clinical, research.
Our goal in surgery at Children's Mercy isn't just to entrust the community, but to develop programs that we can expand regionally, nationally, and be first class both clinically and academically.
For more than a century, Primary Children's Hospital has represented the best pediatric care in the Intermountain West. Each year, we serve more than 100,000 children across more than 400,000 square miles.
At Primary Children's, we're the only level 1 trauma center for pediatrics in the whole Intermountain West.
Because of the expertise, a lot of patients are transferred up to us for our evaluation. And that's fabulous, and that's what we're there for. But you can imagine that is a significant hardship for the family, for the patient, and if it doesn't need to be done, it would be great to hold off on that.
We're working to provide some of the same world-class care available at Primary Children's to kids across the region, but in their own communities. In addition to specialty clinics, education, and training, we are using innovative telehealth technologies to bring our nationally recognized caregivers to more children than ever before, all while saving time and resources for the patient and their families. Telehealth can be applied to nearly limitless care types. We can connect local emergency departments with experts to help a child with a complicated injury, connect our neonatal neurologists to NICUs across the region, support pediatric medical surgical nurses in the middle of the night with a deteriorating patient, and keep children closer to home for their cancer care. As part of our primary promise to build the nation's model health system for children, we're creating one of the most sophisticated pediatric virtual hospitals in the country. With notably improved health outcomes and lower cost to families across the Intermountain West, it's the right thing to do. Our emerging model is setting the standard for others to use and follow.
I got a call from his pediatrician. He said there's a very large tumor in Atticus's brain. So we traveled from Nashville for the very best. Cincinnati Children's is the one that helped save Atticus's life.
I want to hear that intro again.
Yeah.
That was amazing.
Hello.
We're back on, sorry.
Sorry about that. All right, we're going to try this again. I don't know if you saw me just moving my lips, but we're going to talk about artificial intelligence, and we have Carlos Colunga from where again?
Hospital Regional Materno Infantil de Especialidades de Monterrey.
He's from Mexico. And We have Emgoti, who came as my medical media fellow from Turkey. After graduating medical school, and I was fortunate to recruit her to stay on as one of my colleagues now at Cincinnati Children's, helping us in innovation. And Rami Sha'aban, who I was introduced 2 years ago, who is ENT surgeon who is now a PhD and a professor in instructional technology at Utah State University. Rock on. All right. This is the team. They're going to update us on artificial intelligence. Take it away.
So we are going to talk about AI and specifically the generative AI. And we have...
Hold on, Rami, it sounds like it's not working. What's up?
Not working?
No, it's actually on.
It's on, yes. Oh, it's...
You can use it. Switch mics. There we go.
Okay, so it's working here. Okay, so we are going to talk about AI, specifically generative AI use cases in medicine and medical education. And we have three categories of use cases: research, productivity, and medical education. So let's start with that whole question here. So which of the following is false? Is false, okay, so that's tricky a little bit. ChatGPT can help to organize literature review. ChatGPT can analyze data within an Excel sheet. ChatGPT can run statistical analyses. ChatGPT can help in the research design, or none of the above. So what do you think? Any thoughts here in the room?
Do you think, is there anything that you can...
Do you think any of these are false, or all of them are true?
What about the unpaid version?
It still doesn't.
Yeah. Yeah.
Mike. Yeah. Oh, right.
Yeah. We're talking about both of them, yes.
Okay, let's keep going.
Yeah, so it's none of those. All of them are true because, so we are researching how ChatGPT can help us in the research process. And I personally used ChatGPT in systematic review and meta-analyses. And, you know, when you do systematic review, you skim through, you screen thousands of articles, and then you have a title and abstract screening, and then the full text screening. And this process is intimidating. You have to have many people involved in that process. So we tried ChatGPT to do the title and abstract screening as well as the full text screening, and it does great job.
Do you want to explain how to do it?
Yeah, sure. I think we have the next slide here talking about that. So we have a bunch of articles to go into title and abstract screening, and then we asked ChatGPT this prompt. I'm conducting a systematic review of the use of AI in organ transplantation. I need you to act as a data analyst. Please analyze the attached Excel sheet and screen the included articles for title and abstract. By the way, that the AI in organ transplantation paper was published already, so we used ChatGPT in that. Used the following inclusion criteria. We have some inclusion criteria here, and then after screening, the title and abstract. So now we want ChatGPT also to manipulate the document itself. So it's not only just giving me text in an answer through ChatGPT, but also go inside the Excel sheet and then read the data from Excel sheet, add columns to the Excel sheet, and say whether this article is relevant or not relevant or may be relevant. And because we don't trust ChatGPT a lot, I asked ChatGPT also to add a column to explain why the ChatGPT decided that decision. So you have a better understanding about this data, and if you don't agree with ChatGPT, you can manipulate the prompt, engineer the prompt to make it more accurate. Okay, and we get an excellent result with that. We also we had to do the human title and abstract screening also because we want to have a reliable answer, but we did inter-rater reliability between ChatGPT and the human reliability, and the inter-rater reliability was excellent. So ChatGPT could be used in that part. Yeah.
So what is the first cycle and second cycle?
So yeah, okay. So first we wanted to use ChatGPT to give us yes or no question, yes or no, relevant or not relevant, and then we just redesigned the prompt a little bit to make ChatGPT say whether it's relevant, not relevant, and maybe relevant. So we decided to consider all of these versions of the prompt and then make the inter-rater reliability between all of that columns. Question?
I've done this, not for the exact same purpose.
Perfect.
But I don't get the same answer each time. So my question is about reliability. I know humans are not reliable either, but
yes,
you know, it sounds like every time you offer this question, to, at least to ChatGPT, I haven't tried other ones, you get a slightly different answer. It approaches the problem like for the first time every time. I think so.
Yeah, so if you use ChatGPT in the general search, you get different answers, but we created custom GPT for that. So you have you can walk ChatGPT in serial of prompts until you get the most accurate results, and which is just not that difference between, if you run it multiple times, you get a slight difference. And we had to have human reliability here also to just make sure that it is reliable. So, but that's a good potential for the future iterations for ChatGPT, for example. So.
I think also it might be one of the questions that what is the AI limitations when you use it for an actual paper and go for publishing? What is the disclosures that you do for the journals? Do they have any limitations? Do you have any extra information on that?
Yeah, so we used ChatGPT here is as a part of the methodology and part of the reliability process. We don't use it to for example, as an act of plagiarism or writing. Yes. Our journals are very, of course, okay. And we frankly say that this cycle of screening is done by ChatGPT, the second cycle of screening done by ChatGPT, third cycle of screening is done by humans. So, yeah.
Okay. Yeah, you always have to have a human in the equations. So we have to take in mind that these AI models, they help us increase our efficiency, and sometimes we equate wrongly efficiency to productivity, but sometimes you get productivity out of the efficiency. So it helps us be more efficient by accelerating how we do the work, but we always, at least in the medical and the science part, we have to have a human in the equation, because we have to remember that even if we use the prompts that help you get the same results, because ChatGPT is a black box model that we don't know what it is trained about, and they're always changing the weights, it'll change. So it needs us to tell it what to do and to understand and read the answers of ChatGPT.
Yeah, you want to move on to the next one?
Yeah.
Okay.
So let's go to talk about Jenny AI, whose motto is use AI to supercharge your research paper. So what does it do? You open the Jenny AI, which is one of different academic models that has been finally fine-tuned with research papers, and you literally put your prompt. Hey, I want to write about this, and that. In this example, let's talk about pediatric intussusception. You put the prompt, and the first thing that you'll get is a suggestion. You can start writing this. You, because you're the surgeon that has the hand on the wheel, can say, yeah, I like it, I want to modify it, I want to change it in this and that way. And then, the next slide, please. You can also talk with its in-house chatbot and say, hey, I really want to give it this spin. I wanted to research specifically in this. And the chatbot will give you the answers that you're searching for. It will cite papers to you, and it can help you cite on your preferred type of citation specifications into your paper. Next, please. So here, you've decided that, yes, I like what it is saying. I also want you to add this, and that on my academic paper. And it gives you a little suggestion of the summary of the papers that you want to introduce. So we can see how this accelerates your paper writing, but you're still at the command of it. You're still in the helm.
Oh, wait, James.
Next, please. So let's do an audience poll to see how you're feeling about this. So how recent are the articles suggested from the use of these AI models. So they have a cutoff date of 2023. They're older than 5 years, older than 10 years, and they're on par with the latest published research. What do you think?
Any ideas?
Can we see the answers from the international audience, please?
I don't know if the poll is up.
Oh.
Can we see the poll results? Okay. Half the people know what's up.
Yeah. So mostly nowadays they're mostly on par. We just have to research into what model we're using and what library they're using, but it is on par. We just have to remember that they're searching for those latest articles in this specific type of library, which we'll talk about it at a later moment. Well, that was the moment. Yeah. So
also, there's another tool
yeah.
with the Genie AI. It's called Open Evidence, and I think you said this is the difference, that this is not necessarily helping you write it,
exactly,
but it helps you do literature search.
Exactly, which is amazing. This was part of the program accelerator over by Harvard team and the Mayo Clinic, and they specially focus on the Elsevier library. So you can ask any type of question, it will reply in a conversational manner, trying to answer your question while summarizing the papers, the latest papers that it's citing. So it gives you a conversational answer, and then at the end of it, it gives you the papers that you can personally check out to confirm what it's saying. If you want to press the details, it gives you a bigger summary, and then it suggests, hey, so you're talking about these
like
things?
You just cited Dr. Russell's paper in the second part.
Yeah. And if you wanted to go...
accurate.
Yeah. And it also gives you suggestions. So I know you're talking about the appendectomy. Hey, you could also talk about this and that, which is up in the next slide.
And you can ask follow-up questions.
Yep. Yeah. So it's pretty great.
So what would you say the personal practice changes for your part?
For my part, okay. So we are going to talk about the medical education part. Is that right?
Medical education is coming next.
Okay.
We're going to first talk about the productivity part, but I think it kind of summarizes that large language models can enhance the efficiency and productivity when you do research by analyzing the large data sets for you, or you can use those tools to help you write. This is especially very important for the international audience that have, once you have something on hand and work on it is way easier than writing something by yourself from scratch. So these large language models also can be an editor and help you write these papers. And we're going to move on. Yeah, Jose.
Dr. Holcomb, what's the JPS policy about these AI tools?
I think we wanted to submit something. They asked if we used it.
Yeah, so you can use it for background information, but you can't use generative AI. That is, to have AI write you the paper.
And are you making sure it's not being used, or you have to disclose it at some point?
Well, first of all, if you used it and you disclosed it, it's probably not going to get accepted. So. But we being Elsevier, has tools to figure out if it's been used or if it's being used. So that's sort of the policy, is you can't use generative AI to create your paper, to write your paper. I think it's okay to use it. You could, for language, it's probably appropriate. And for literature, background information, it's certainly appropriate.
I think it all started a couple years ago when ChatGPT started getting used in different fields. The first couple papers were written, and ChatGPT was among the authors. And I think it's not been permitted anymore. You cannot do that. But I don't know. Probably it's the same for all the journals. You cannot ask ChatGPT to write a section of it and show it in the authors.
Yeah, most of the journals I see is just asking you if you want to use ChatGPT, you use it to just enhance the writing style, not create the ideas. So, yeah.
And our next question, because we're going to talk about ChatGPT and other AI tools and how you use to enhance your daily productivity, not necessarily for research. And we asked the audience, how often do you use ChatGPT or similar AI tools? It could be Claude, Gemini, anything. It's a spectrum from goes to never to always, and 1/3 is never. Whenever Todd sees those numbers, he kind of have like a heart attack every time he sees people does never use ChatGPT or AI. So if we first start with productivity part with MeetGeek, this is one of the tools that helps you, you basically synchronize this tool with your calendar. It jumps in any meeting that you attach to your calendar, and it takes notes for you. And at the end of it, it sends you a mail of the transcription, notes, and the summary. And it basically tells like who were in the meeting, what was the summary, and what you need to do. It goes with the recording, and it assigns action items per person who were in the meeting. And Fireflies is a similar one with the MeetGeek. If you go look in the internet to see meeting summarizer AI tools, there are like a bunch of them. Most of them does the same job. They're on different price points. It's most of the time it just personal preference. Yep. They mostly do the same thing. I know you start using MeetGeek and then you transfer to Fireflies because we influenced you?
Yeah, I think Fireflies, yeah. So I used MeetGeek, I used the paid version of MeetGeek, and then Fireflies, the free version, and then the paid version. And I think...
Yeah, when you invite Rami to a meeting, shows up as 4 people. Rami, AI note taker 1, Rami, AI note taker 2.
The human version is not there, is that right? So I think Fireflies, my personal preference is because it has also action items that, so after the meeting, it gives you the action items for what's next. So it just keep you informed.
It is great. I use Fireflies because of you guys. I started using it. I saw you were using it, and I
Carlos also comes as 2 people every meeting.
The issue that we've run into, because I was addicted to it, I needed it because it gives me takeaways and all the key points.
Here's what you need to do.
Well, but then our hospital people got worried, especially with some of the meetings I was having, that it was auto-recording everything.
Mm-hmm.
So you just have to figure out what's the safe way. At Cincinnati Children's, they now have one that's approved by Copilot, that's approved by the hospital. But even then, our lawyers asked me to stop using it on half of my meetings because they're legally sensitive.
Well, you talk about confidential things.
Yeah, confidential things. So we're going to make progress with that because this is such a valuable tool, and we have to get past the security part of it. But it is.
Yeah, especially especially if you're using at an institution level, it needs to be a lot of preventative, preventions be taking place for security purposes, especially like you and Dr. Van level executive meetings, but like you and me in a meeting, Fireflies can't record that.
Yeah.
There's not going to be that.
Yeah.
We've actually added it to our platform, so we use Copilot, and that's the only thing that's basically approved, for Karl Storch to use. In regards to note-taking or getting information, recording stuff, and then analyzing it afterwards.
I think it's the same at Cincinnati Children's, and they generally send us weekly AI guidelines of how should we use it and what kind of information should not be used when you use Copilot or ask for meeting summaries and everything. And I think that's a good step to endorse people to use, with not giving away the secrets of the company, basically.
Yeah, we have to have these talks. We have to learn how to use it because it's here to stay. We can't close our eyes and don't admit that everyone's using it to increase their efficiency and improve the way they manage their day-to-day lives.
Yeah. Zoom AI basically does the same thing because some companies have Zoom instead of Microsoft. But the plus I saw at the Zoom, if you're late to a meeting, And you have Zoom AI Companion. You can ask if your name is mentioned, what people ask you to do, and recap the meeting until just before you join what happened. So I think that's a very cool thing. And if you're generally late to the meetings, I would definitely recommend.
1 minute.
1 minute? Okay, sorry.
Maybe just hit the high points. What are the
Okay, this is Todd's favorite. Read aloud GPT. We created for it. You can use this QR code, and you can use by yourself. It basically helps you listen your long emails or any text that you need to listen to instead of you read. We know Todd talks
Yeah.
He has to read a lot of things, with the emails and everything. And sometimes, what do you call walk and talk?
Twalk.
Yeah. So it's hard to read when you walk.
So
you listen to it and you use the ChatGPT to have conversations.
Instead of an audiobook, I will drive. I'm about to drive to Cincinnati after this, and I will talk to ChatGPT for an hour about a book. So I'll say, summarize this book, and I will go back like a book club. I'll say, tell me now, what does it say about this? Tell me, let's go into chapter 2. I want to know this. I don't get this. So I will have a conversation while I work out, while I am driving. Yeah.
And I think this is one of the most important ones that for this audience here. Todd said he's getting a lot of requests for a letter of recommendations, and we created this GPT for him, and you can use the QR code. If you can put the slides up here.
But they keep saying we created GPTs. It's very easy to do. So if you're using the same prompts over and over, and it's a series of prompts, you can create it and just keep reusing it. So when I have a letter that I have to write, it goes through for me.
Yes, so when you use this QR code, you're going to go to this letter of recommendation GPT. All you need to do is upload the CV, cover letter. Why are you writing this letter of recommendation? It's going to give you a draft. You can start working on it and personalize it for the candidate. We do not recommend the first thing you get from ChatGPT to use it, but it's a great start for it.
It will sometimes be over.
It says this person is from heaven.
Amazing, and so you have to. I mean, I actually almost always come back and say, I really don't know this person. I'm giving a reference, so please tone it down. And then it's like, this person's very good, blah blah blah. So you have to just tell it what you want. All right. Like with Halpern, I'm going to say, please really tone this down. He's not that good.
Do you want to do the medical education real fast?
Yeah.
Sure.
So, just 1 minute.
Go we'll just talk quickly that. So and the medical education part, if you want to have a personal trainer, we use also ChatGPT and other generative AI in that. So you can, for example, ask ChatGPT to upload a guideline to ChatGPT, and then ask ChatGPT to create a training session, an interactive training session between you and ChatGPT.
Can we put the slides up? Thank you.
Yeah, so you can ask ChatGPT to create a training session out of a guideline, so it doesn't have to go into hallucinations or fabricating information. It takes the guideline, and then it creates a series of interactive questions where you can interact with ChatGPT and get trained on specific things. So, for example, that's an appendicitis case that we asked ChatGPT to create problem-solving activities, and also we asked ChatGPT to score these activities and give us feedback at the end. So that's the feedback that it gets at the end.
On a similar note, you could also make it do any type of case, step 1, step 2 type of case, any type of case. You can ask for it. You do the correct prompt, and with that, it'll help you do the medical case in a step-by-step manner, and at the end, it will give you feedback.
All right, this was awesome. I let us go way over. That's my fault. I'm sorry.
AI is cool. Keep using it.
This is phenomenal. These guys are great. We're going to keep doing a series of courses throughout the year for these kind of questions. But guys, thank you so much. That was awesome. Miguelito. All right. We have our least qualified surgeon talking now. Miguel Gilfan. No, I'm just kidding. Miguel is Chief of Pediatric Surgery at the Cleveland Clinic. And he is going to talk. What are you going to talk about? Gastrostomy? Go for it.
Thank you. Thank you for the invitation. And Todd asked me to talk about something he really understands first, and actually that he actually can do in the OR. So that's going to level down everything. Just simple little things, so you can do it and actually understand. So we're late, so we're going to be very fast. Next slide, please. So we're going to do two little topics. Next one. Liver retraction in Nissen and sutureless gastrostomy to avoid some complications. So next one. So basically, to retract the liver can be sometimes very cumbersome, and there are different, could be a 16 kilo baby, a patient, a 45 or 1.8. So there's different ways to do it. Next one. So let's see what you do with, how do you retract the liver in a Nissen?
In what size?
Any.
In a neonate?
Okay, I use the same one in everyone. That's why. Can we get the poll?
You don't know how I let Miguel do it on there.
So they used to have the Diamond Flex 3 millimeter liver retractor, which.
Okay, so almost a third each one. So there's you can see here the different typical things you can use to retract the liver. And something could be cumbersome, can be not suitable for the size that you have the patient. So we basically, I learned this from Jorge Godoy from Chile, actually. Next one. It's a very simple way to retract the Nissen. This actually is a real photo of Jorge. It's a Nissen done in a small baby without trocar. But this thing, can you come back? That little thread is basically doing the retraction of the liver. Just a little simple thing. So basically what it does is, here is a suture that is entrapped in a little stop, or there will be a little silicone, a Foley, whatever, and goes into the abdomen and goes outside. Next one. Again, the same picture. This is the rubber, and this is the suture coming out. Next one. And this is basically, this was described by a surgeon called Nakajima in '99. Next one. That's how it looks. So basically, you're going, can you stop it for a second? You go, usually you see the liver, and you try to basically map where you're going to be the suture coming in. From the left subcostal, you go in, go please. You go in, this is left subcostal, you get to the right cross, don't stop it, go back. Yeah, start again. The one, yeah, go start. Yeah. So go to the right cross around 11 o'clock, and then you go out to the right, left of you or right of the right ligament of the patient. And just go a little bit, it's not a very deep suture, and you go out, again subcostal, on the other side of the round ligament, and you pull that thread that will be stopped at the level of the skin, and basically use those two threads to retract the liver as much as you want. In 90% of the patient, you only need one thread.
It never cuts the liver?
No, never. If you're gentle. Of course, if you're gentle. We use this in 1.8 kilo babies, and there's no problem. Next one. Next one. So again, we're going inside left subcostal. This is the suture stop. So you go across some little rubber thing that stops the suture going into the abdomen. Next one. And you hold it with a mosquito, whatever, in the outside. So it's very easy to do. It takes actually 1 minute, and actually the exposure is amazing. And you don't have more trocars or instrument, and you have more space within any patient. Next one. The next one, because of the time. And basically you can see here the two things.
Is it frozen?
Next one.
Looks like
or not.
Just keep going, those are animations. Yeah.
So go ahead, go next one. So for big livers, no.
Go back.
Go back. Go back, go back. Or not.
Now forward.
One. So this is the view. You can put one in the left and the right cross if the liver is too big or the left biliary is too big. So with that simple thing, the exposure, this is the Nissen at the end, is really, really simple to do. It takes, it's no technology, it costs $2 and takes 1 minute. Next one. Any question of that? You understand, Todd?
One more time.
Thank you. Okay. Usually when you do this could be just a gastrostomy with an Nissen. Usually you have, what usually you do is put these little sutures to prevent the Mickey button of the gastrostomy tube pulling down from the stomach, and you tie these knots on the outside, and usually you may have some problems. You can have infection, a removal, skin retraction, or all of the above. Anyone have all of the above or some of them? Paul? And this is usually what you see at the end. This is a small baby, a 1 kilo baby. And usually you have some problem in some of the patients. So to avoid this, and this is I learned this from my hospital, for a surgeon called Marcela Santos. I know it's published already, but we'll start doing it. It's a very simple thing. Try to avoid those complications. Next one. Next one. So usually this is the usual problem that you can see. Next one. Even to that. Next one. So basically what we're doing is doing exactly the same, but instead of putting the sutures and tie them outside, we're doing it under the skin and just leaving the knot under the skin, usually with PDS or Vicryl. Next one. And basically, when you decide to do the gastrostomy, you do a little incision in the skin in each side of the gastrostomy site. Next one. You dissect a little bit of the skin, and you can pull an angiocat or whatever. It's like a inguinal hernia thread to pull the suture out. Next one. You pull the 2 sutures inside. I'm going to show a short video. Next one. And then basically, you have the 2 sutures here under the skin. Next one. This is a short video. So basically, you decide that you do a gastrostomy side. You do very small, skin incision in the other side. You dissect with the mosquito, just to leave a space for the knot. You put 1 suture down through that little skin incision. You grab it from the inside. This is actually doing a Nissen and a gastrostomy at the same time, obviously. You decide where you put those stitches in the gastrostomy side. One side first, the other side again, and then you put this. You try to pick up the thread that you put from the outside and coming out actually in the same side of the little skin incision. So it's easily to do it with this technique. This is the same as the inguinal hernia repair. And you pull it out, and you do that in the same side each one, and then basically. So you have the 1 stitch there coming out, both ends. You do the same on the other side, coming out again with the angiocat or a spinal catheter loop with usually PDS. It's easily to get that suture back. And then you do whatever you do to do the gastrostomy. You can do a percutaneously. We put a bovie inside, burn a little bit the stomach, and put the G-tube or the Mickey bottom directly. So the 2 threads are there. We bovie the stomach. Usually this is the way we do it. Do a little incision with a mosquito, and then put the Mickey bottom, the G-tube, and then you basically what you do is knot this tight under the skin. So at the end, you won't have those knots outside, going around the Mickey bottom of the G-tube bottom, whatever, and basically you avoid mostly all the complication having this knot in the outside in the first weeks. And this is the final. Next one, please. This is the final view. And just before, I have the opportunity and the honor that Jeffrey Ponsky, you know Jeffrey Ponsky? No. Okay. I invite him about 2 or 3 weeks because I was honored to have him in my OR to help me in a PEG. Okay, I want to have a PEG done with who invented the PEG. So I invite him to the OR, and I told, please teach me all the small details about what doing a PEG in a big, was a 19-year-old patient. And now I understand why you don't understand anything. Because how you were, taught in your life. Can you show the video, please?
Oh wait, does this have audio?
Yeah, but we need an audio, please. So he was teaching me how to do a PEG. Basically, I've done it all the time, but I want to know the little details. Go. We need a lot of audio, please. No, it's there. It's in the next one. Sure. Dr. Ponsky video.
While we're waiting for that,
Yeah, and that's a nice suture technique. In the kids under 10 kilograms, you can take those sutures with the needle through the abdominal wall and get the stomach directly by holding up on the stomach through the
the thing
G-tube
is
site.
it's too difficult to come out in the same incision.
So the way you do that is you come out through the skin, but you don't take the needle all the way out of the abdominal wall. And then once it's above fascia, you back it out under the skin and come out the same hole you went in. It works really well under 10 kilos.
I like it.
So when you start to get thick, you can't do that.
No, without going to the skin.
You're almost out of the skin. If the swedge of the needle comes out, you have to redo it because you'll never get it to dunk.
I like it very much. Thank you.
Yeah.
Do you have it or go put some audio, please.
A 4 millimeter transverse skin only. He went in? No. Okay. Oh, okay. You done? That's enough. What are you making, a whipple? All right. Now take the needle. I love it.
That was awesome. Nice job. All right. Thanks to Miguel. Great presentation. All right. All right, so we got Carlos now, right? All right, so one of the things we wanted to do from now on going forward is to highlight different regions that have their own updates that are specific to that region. So Carlos wanted to talk about some of the updates from Mexico.
Yes. Where are you from again?
Monterrey, México, Hospital Regional. Okay, so let's talk about different updates in Mexico. And we'll start with the beautiful, amazing Monterrey, Nuevo León. And we'll talk about CO2 laser for pediatric surgery. This has, with my partners, Eric Silva and Jorge Garcia, in the private hospital in Tech Salud, we've been working on this, the use of this device, okay? So let's start with a clinical scenario, a 3-year-old male with chronic balanoposthitis, recurrent infections not responsive to medical treatment, and it has a tight phimosis with painful urination reported. So, which is your preferred weapon of surgical use to treat the circumcision? A, scalpel, B, electrocautery, C, CO2 laser, or D, a specialized stapler? Okay, how about anyone in the audience? Scalpel?
Well, we don't, I mean, how many people in this room deal with phimosis? All right. Yeah, what were you going to say, Steve? Just every now and then. Yeah, okay.
Perfect. Bipolar diet therapy is missing there. But bipolar diet, yeah, it would be a really good choice. But my friends, you've just been bamboozled because this was a rhetoric question and I wanted you to ignore CO2 laser. And I'll use this rhetoric question to convince you that CO2 laser is not a black diamond, it's really a blue square disguised as a black diamond. Why? Because it has the potential to outperform conventional circumcisions and other surgeries, but I'll use circumcision as a proof of concept. It can give you faster operative time, reduced pain, lower rates of scarring, and an amazing cosmesis. Here, we have some proof of concept, and this is the thing, that when we hear about the use of CO2 lasers for surgery, we think, oh, this is new. But this has been reported since 1970, since 1980, since 1990, in the 2000s, etc., etc. It's just not well researched in pediatric surgery. So I know when we hear lasers, we think, oh, the future, we think Star Wars, but Star Wars is 50 years old. So there's a lot of proof that this could be a really viable tool. So next, please. Next. Okay, well, while we get the next one, We've been getting over in Monterrey by using CO2 lasers and JAG lasers, which is the way it works is the laser emits infrared light. It is highly absorbed by water and biological tissues. Depending on the nanometer wavelength that you changed, it absorbs differently, but we're using it in the spectrum of 920 to 1400, which is really well absorbed by water. And it's really, really, and I'll emphasize again, really effective for precise cutting and ablation, which permits bloodless or very, very minimal blood in your surgery. So it does reduce blood loss. We have great precision and control. We have great reduced pain and edema, and shorter operative time. The disadvantages is, as an initial inversion, it is quite expensive. It's around $5,000, around 100,000 Mexican pesos. It has an increased learning curve. Initially, it has high initial cost barrier, but when you look at the papers, you can justify it because it diminishes by a great deal operating OR time and lower complications, which at the end gives you better cost savings for your patients. So you need ocular protection and you need specialized training required. So now let's go to a step one type of question, which we all hate. Which type of tissue is most suitable for laser surgery, especially at this wavelength? Muscle tissue, mucosa, connective tissue, or bone tissue? Amazing, yes. And people all around the world are right. Mucosa tissue is, of course, filled with mucus, which is 95% water. So it reacts really well to the laser. And if we think about it, what tissue or where in the body could we use this? Next, please. Well, we have a wide range of places where mucosa is present. So I'm going to talk a little bit about where we've used it as a team over in Monterrey. We used it for circumcision, 56 patients. We used the sleep technique with the dorsal slit. We used cyanoacrylate adhesive, but we put points in the coordinates at the north, south, etc. And we've only had a 3% complication rate, but a partial bone dehiscence that could be managed in a conservative manner. We've also had it, well, here's an example of how we've used it, but I'm going to go ahead because of time. Just look at the scarring profile. It's amazing. Low pain profile, we only use Prorenata ibuprofen. Our surgical time is around 10 minutes plus minus 3, and amazing aesthetically results. Next, just proof of concept papers. We've used it for frenolectomy, 47 patients, low pain profile, no suture required. Next. Perianal fistulas, we've done it for 4 patients, fistulotomy, a planoidal cyst, 12 patients, we do laser ablation, and if there's a sinus tract, we also ablate it. It's great for searching for the necrotic tissue. Lower labia fusion, and next, condylomatosis, great for ablation. And this is just papers that do proof of concept from 10 years, 5 years, etc. So, just to convince you, it has less bleeding, lower pain profile, shorter OR time, high equipment cost, need for specialized training, and the lack of availability, with a little special hyphen, because if we're in contact with the dermatology department, they have lasers. And so we actually, the wife of Eric is a dermatologist, and we started leasing it from them at the beginning. Next. So I'll jump the questions up until the end. Let's go over to beautiful Guadalajara, not as beautiful as Monterrey, but it's also beautiful. Percutaneous track, the digestive endoscopy and airway team from my surgical alma mater. So, clinical scenario, 2-month-old male, 20 weeks of gestation, unsuccessful extubation attempts, and 1.6 kilos, which is 3.5 pounds for the non-universal type of weighting. So, which would be a contraindication for percutaneous tracheostomy? Age, no contraindication, the weight, or pulmonary pathology? Yes, none. Well, there's multiple meta-analysis and systematic reviews that have found it to be really, really accessible in all types of patients. Here we see the systematic review. It emphasizes on the Greeks technique, and I'm going to tell you about the technique that we are using over in Guadalajara. Next, please. Next. Next. Okay, advantages. MIS, easy technique, fast and safe, nowhere needed. So the advantages that we know from Percutaneous in adults. Next. And here's our video of our adaptation of the Ciaglia Blue Rhino technique. We do the incremental dilation. Can you put play to the video, please? What we've done with the team in Guadalajara, they've adapted. No, it's just, yeah. No, they've adapted. It's the same technique, but they've adapted with the use of percutaneous nephrostomy dilators, the Amplatz dilators, so that you can use it on patients that cannot be fitted with the Blue Rhino. So the technique is pretty standard with the Blue Rhino technique, but you'll see the little Amplatz dilator that's also been done. So they do the access, they dilate. You have your push dilator, you introduce the guide wire, and then on the table that we're gonna show in the next slides, we use the equivalent dilator for the track tube that our team personally searched for, which would be the specific dilator that could be used with the specific cannula time. Shout out to Dr. Roberto, Dr. Janoski, and Dr. Trujillo, because they did this by actually looking at which one fitted in what cannula. So next. Disadvantages, big learning curve. You need the bronchoscopy equipment. We use it with the flexible bronchoscope. You need a skilled bronchoscopist. Immediate recannulation is impossible, which I'll talk about it in a little later, and specific dilators are needed. Okay, since 2017, more than 180 patients, low morbidity, 1%, low mortality, also 1%. Yes, the main contraindication that I would say is you really, really need the specific team, because I've seen it being tried by people who are not as skilled, and it was the 1% mortality.
How many here are doing Percutaneous? Does anyone do that? Okay. This is awesome. Thank you.
Thank you. Appreciate
so
it.
much. This was great. Thank you. We're on to our last session, and this is about chest wall pathologies. Patricio, come on up. We have Patricio Herrera, who comes from Chile, and what's that? Another Chilean. We have so many Chileans here. Taking over. Whit Holcomb is going to be moderating, but we timed it perfectly. We had someone from Australia at bedtime, and now we have someone from Australia at morning time, 5:30 a.m. So do we have, is Margaret is she on the call there? I don't know if she's on yet. She'll be coming in as soon as they bring her. You'll let us know when she's on. So why don't you guys take on, you got the mics there? Perfect. So just let us know when Margaret's on. All right.
So I'm moderating this, there she is. I'm moderating this final session. And I'll let Dr. Munch go on and present her talk to the group. Go ahead, Margaret.
Good morning, everyone, or good afternoon, I should say.
Morning to you, I understand.
Yes, correct. Apologies, I can't be there in person, but thank you for having me. I guess I wanted to present more our experience here at the Children's Hospital at Westmead in Sydney. I work alongside Professor Jonathan Karpolaski, and we have about a 10-year experience with our chest wall reconstructions. I'm sorry, I can't see the slides.
Can you not see the slides still?
I can see them now. Thank you very much. So essentially, I wanted to present just one case because it's quite a short time frame, and I understand you guys are running a little bit behind schedule. It's of a 14-year-old boy with osteosarcoma. I'll go into more detail of his case, what our current practice is and our experience over the case of the last 10 years, and maybe touch on future innovations or have a discussion amongst all of us on what's happening out there and where we think things are headed. Next slide, please. So I present you with a case of a 14-year-old male from country Australia. So he lives 5 hours from our institution. He presented with back pain and inability to walk. He was otherwise fit and well, and he was transferred to our institution where examination revealed an incomplete cord injury with absent lower limb reflexes and altered motor and sensation below the level of T6. If you look to the bottom images, I haven't given a lot of images, but you can get an idea of the massive tumor that was existing. And he underwent, it was arising from the 6th rib and had extension into the spinal canal, and he underwent an emergency posterior laminectomy and partial tumor debulking initially for his cord decompression between the levels of T3 and T7. That histopathology confirmed an aggressive osteosarcoma, and he subsequently went on to have further imaging with a PET scan, which you can see in the upper 2 images, and commencement of neoadjuvant chemotherapy on the protocol of AOST 0331. From there, I don't know if you can appreciate in the top right-hand corner on the PET scan, you can see a PET avid lesion on the right-hand side, just next to the sternum. He underwent a radio-guided occult lesion localization using technetium-99, and we did an anterior thoracotomy to remove that lesion, and that confirmed also aggressive osteosarcoma, replacing that lymph node. Next slide, please. Following his adjuvant chemotherapy, obviously we had our MDT, and we had to consider what was next in terms of his oncological surgical management. So I guess I put this poll to you guys to get an idea of what people feel are the most important and critical factors when choosing a reconstruction method in our pediatric population.
Can you get that slide up? I was just going to ask our in-studio audience what they thought the answers, or the best answer should be. It's a difficult case. Dan, do you have a thought on this?
Yeah, I think, first of all, it's a tumor case, so the first priority is to make sure you do what you need to do to control the tumor. And then the slides down, but I think structural integrity and long-term viability are probably the most important thing, more important than cosmetic result.
Coco, do you agree?
Yeah, I agree with that. This is an osteo, but in a UN that is much more common, we need to use something that we can use with radiotherapy also. So it's much more important. So that's the main.
Do we have the poll results?
Sorry, so next slide.
There it goes.
I'm sorry. Perfect. I can't read that, so maybe you guys could tell me which color is associated with which answer of the poll.
So D is long-term durability, structural integrity, and C is impact on respiratory function and quality of life. So
yeah, I think
long-term durability is about 2/3 of the answer.
next slide, please. So I think, you know, from what we've discovered and what we're seeing, these are all kind of rare and challenging cases, and most of the reconstruction needs to be tailored to the needs of each of the individuals. And I guess location and size of defects associated with your resection are going to impact your influence of the particular type of material you use. There's not a right or a wrong answer, I don't think, in this case, and there's a lack of clear evidence-based guidelines for reconstructive materials, and a lot of the literature is coming from adults. I think, I'm not sure who mentioned, but also you need to, apart from these three things, you also need to consider radiolucency. So in terms of surveillance and adjuvant radiotherapy as discussed. Next slide. I might talk you through a bit of this kid's surgery. So essentially this was a very long combined case with our spinal surgeons and our thoracic team. The spinal surgeons commenced and removed all of the vertebral bodies between T4 and T7 and inserted a cage. And we resected ribs 4 to 7. The tumor itself was arising from the 6th rib. Evidence on the initial mapping for planning for the resection showed a few lung nodules on the right lower lobe, which we resected. And during surgery, we found a tumor thrombus in the azygos, which extended into the SVC. So these operative photos can show on the extent of the resection. And in this next slide, you can see us placing a Gore-Tex patch, a cage of the spinal canal in the middle photo. And then we tend to use resorbable and biosynthetic materials to do the reconstruction. And we have 2 systems here in Australia, one by Stryker and one by KLS, where they use the resorbable plates, which you can see being molded in the water bath to fit or to reconstruct the chest wall, the rigid part of the chest wall. Next slide. You can see we secure these. We don't use the recommended resorbable screws that come with the plates, but we use the K-wire drill to drill through the remaining ribs, the 2 millimeter, and use Prolene or PDS sutures to secure the implant. Next slide. Following this, we place a permacol on top of that implant and subsequently use a muscular flap, in this case the latissimus dorsi, to cover the permacol, a pedicled flap that is. And from there we close. Next slide. So just in general, the delta plates or the sonic weld system are poly-L lactide and polyglycolide and poly-D lactide plates. They have a strength of sort of 78% at 2 months and 50% at 6 months. And I think most people are familiar with Permacol, which is the porcine dermal collagen matrix. Next slide. This is some of this child's post-operative images in the early stages, where you can see the cage on the vertebral column and his outcome in his CT chest and his immediate post-operative X-ray. Next slide. In terms of our 10-year experience, most of our resections have been oncological. We have 8 patients, most of them male, mean age of 4 years, and our follow-up's a little bit extended on from this, but we don't have the new data yet. Next slide. In terms of complications, we've had early post-operative wound infection in 1 patient, which was treated with IV antibiotics. We've had sterile seromas in 2 of our patients in the early stages, 1 at 2 months and 1 at 8 months. Again, both treated with IR drainage, and 1 case of scoliosis on the follow-up, which is minor and being followed by our spinal team here, but the child hasn't had any intervention to date. And unfortunately, we've had 1 death from metastatic Ewing's. However, this was, we maintain persistent local control in this patient. Next page. I've just put up a couple of the more recent articles that I found in the literature search. Most of them, there's 2 systematic reviews in kids. They're with minimal patients and a use of a multitude of varying tissue replacements. Next slide. In terms of recommendations going forward, I think in our institution, these are rare cases. Again, I think they're challenging. I think the reconstruction should be tailored to the individual patient. There's, again, a lack of high quality evidence out there, and we don't really have any long-term follow-up on the outcomes of these patients. We tend to choose, like I said, semi-rigid materials, which are bioabsorbable, and biosynthetic, more flexible materials in terms of our reconstructions. I think in terms of moving forward, bioengineering of tissue replacement and 3D dimensional printing may be the way of the future in our chest wall reconstructions.
Well, that was fantastic. Thank you so much for sharing your experience with us. The patient that you presented, how is he doing?
I didn't go on because the talk was meant to only be 5 minutes, but unfortunately he's had a relapse just under 18 months following this surgery close to his sternum, and we did a further chest wall reconstruction where we excised his entire sternum and costochondral cartilages and anterior ribs and replaced it with a cement mesh. He's currently having ongoing adjuvant chemotherapy.
Well, that's fantastic. Anyone in the audience have a question for Dr. Blanch? Okay, well, listen, thank you so very much. Please give Jonathan my best. He's an old friend of mine, so tell him hello for me.
No problem.
Thank you.
You're welcome.
All right. Last but not least today, Patricio is going to talk also about new strategies for chest wall problems.
Hi everyone, thank you very much for the invitation. I would like to talk about a quite rare pathology, but now and then you see one, and if you run into it, you're going to have a strategy, right? So we're gonna talk about asymmetric pectus arcuatum, what to do with it, how do we do it, what to do with the asymmetry, and finally how to stabilize after resecting. Next, please. Does anyone in the audience have any experience with 3D modeling on organs, tumors, or cutting guides? Yeah, good. Do we have the poll results? Nice. That's very nice.
Yeah, there's a lot more experience than you might have thought.
Yeah,
I would
yeah.
have thought.
Sure, sure. Next, please. So we start with the CT scan. We manage the DICOM data to make a model, a virtual model of the sternum where you can appreciate the asymmetry. Next, please. Has anybody had problems with sternal asymmetry during surgery? I mean,
Can you define sternal asymmetry? The question was, can you define sternal asymmetry?
You have an arcuatum, right? But one of the sides of the sternum is much more curved than the other one. So the wedge that you should take out is not symmetric.
Okay.
So how asymmetric do you do it?
Yeah, I had 4 last year, but they were all symmetrical.
Okay.
Yeah.
So here we go. Do we widen the wedge on one side? Do we widen the wedge regardless of bone gap? Do we resect costal cartilage on the protruding side? Or do we compress afterwards? What we can see here is a patient with a quite striking angle in the sternum, which is not symmetric. One of the sides is much more curved than the other. Next one, please. So we start with the, next, please. So with the reconstruction, you make a perpendicular line to each one of the plates or the flat surfaces, and you make a triangle on each side of the sternum. With the sides of this triangle, you make cutting planes, and with those planes, you delineate your wedge. Yeah, that's the way. So these planes are not even. It's not it's not easy to, when it's asymmetric, it's not easy to do it like spontaneously in the OR. So we do it over and over as to produce the lesser gap in the posterior cortex. Next one, please. Then, when you have your planes, you mount them on a mold of the anterior surface of the sternum, of the asymmetric sternum. So this green piece of plastic, which is 3D printed, will have 1 fit and 1 fit only on the anterior surface. Then you stitch it with, you screw it with screws on the anterior surface, and you pass the piezoelectric scalpel on these ridges. So next, please. That's a video? Could you play? Yeah. So you had this simulation beforehand, before the OR, where you can see that the posterior cortex is barely scratched. Next, please. So you get this, the one on the right side is a video, if you might, please. This is an actual cutting guide that's already being used. You can see the scratches on the surface. So you see the lines. Next, please. On the left side, you see the plate in place. We are using the piezoelectric scalpel, which gives you a really fine line cutting on the bone. And on the right, you have the plates in place. Next, please. You can do straight bars or these figures to stabilize the sternum. Next, please. So if after resecting the bone wedge, you still have the rib arches to be asymmetric, with one side protruding more than the other, what would you do? Would you further resect sternal bone? Would you do bracing after surgery? Would you do rib repositioning or perichondral resection and suture rib shortening?
So I think this is an interesting problem, and for those pediatric surgeons who see a lot of chest wall pathology, whether it's excavatum or carinatum, the first time you see one of these, you'll think it's a carinatum. But you're obviously wrong, and it's the wrong treatment. And John has more experience than I do. I've only seen 3 in my career, but it's striking how different it looks like from a carinatum. But you can't brace it. Yeah. But the surgery itself is not easy to do. So before you do it, be sure you know what you're doing, or send it to somebody who does know what they're doing.
Absolutely. Well, the methodology we use, you go on the left side, you see the angle on the sternum, and on the right side, you see the same patient after surgery, and you have pretty much 180 degrees of the correction. These are 2 different patients with post-operative results, which both are very happy about it. Next one. Thank you very much.
Yeah. Really good results. Do you use this technique for a symmetrical?
Asymmetrical.
Just asymmetrical?
Yes.
Okay. John, do you have any comments, thoughts?
Yeah, I wish I knew about that technique, but I like it because it's what I've done with these is essentially, because I noticed on your postoperative photo there's that the costal cartilages are still a little bit prominent on each side. So I kind of start with a ravage procedure. I remove all the costal cartilages, and then I completely resect that whole anterior projection. So the issue of asymmetry is kind of gone, because I completely excise that. And I notice you use the Zimmer system, which is beautiful. They make a sternal closure system that has a loop wire that the cardiac guys use, and if you turn it 90 degrees, you can use that to take a completely bisected sternum and bring it together, and it comes back extremely flat. But that's much more involved than this is a much more elegant way to do it. I'm curious that you mentioned a scalpel, an electrical scalpel that cuts the bone.
Piezoelectric. The piezoelectric is the one. This is the one that maxillofacial surgeons use in the maxilla or in the
jaw.
On the jaw.
Because that's a beautiful way.
It's a beautiful line.
Yeah. Yeah, they may have.
Yeah, I just used the hammer and the chisel, I guess.
Yeah, that's what I used to do. That's what I used to do. A hammer and chisel.
Yeah.
All right, thank you very much. Beautiful work.
Thank you.
All right, thank you. Well, Todd, that about wraps it up from here, and another great update course. Congratulations.
No, thank you. This was a great way to end it, which is something that, I love. I was sitting here thinking, I always expect fights to take place, and they're not happening, probably because the stuff that's been chosen and weeded out is stuff that is pretty compelling. And it seems like people are usually like, yeah, I think I'll try doing that. So this was a phenomenal session. The whole day was fantastic. Cecilia, thank you so much. Good luck with your next step of your career at the Cleveland Clinic. Em, thank you so much. Red Bicycle, Isla, Kiki, Rami, Claudia, Julie, everybody, thank you so much. Thanks to all the hospitals that have sponsored this, that continue to allow us to educate the world and make it free to the world so it's democratized. And I'm excited to see the videos. If you missed anything, we'll have everything available. So with that, I guess good morning, good afternoon, good evening, and we'll see you next year. Thank you, everybody.
Enjoyed it. Nice case.